Yes, ma'am. Start, ma'am.
Yeah. Hello and welcome, everybody. Today we are having day 3 session of ICOG certification course in infections in pregnancy. We have a tremendous feedback of appreciation of day 1, 1300 registrations, 625 live audiences, and day 2 academics was next level. And we covered important topics yesterday: labor, no, labor room and cesarean section prevention of sepsis. We had topics on MDR, multi-drug resistant organisms and antibody stewardship. We had genital tract and intravenous infection session on that, and infection prevention and optimization, puerperal sepsis, septic thrombophlebitis, maternal sepsis advances, sepsis care bundle with guidelines, and a panel on severe maternal sepsis and septic shock with renowned speakers and chairpersons to chair. The panel was mind blowing and everybody was there and very interesting, and it was taken. So, I would like to invite a chairperson, vice chairperson, Madam Sadhna Gupta ma'am, for her address and review of the today's topic. Welcome, madam.
Thank you, Shashi. Warm welcome once again for the third consecutive day of ICOG certification course for infection in pregnancy. Like Dr. Shashi has said that in the previous 2 days, we have covered the non-obstetrical infection, especially focusing that the tropical infections, which are more prevalent in our country. Second day, we focused on the obstetrical sepsis right from the beginning, preventive aspect to the critical cases in the ICU care. And today we are focusing on fetal infection in pregnancy. And just 1 decade ago, we as a obstetrician were not very well aware for the fetal infections and how the maternal and fetal infections are correlated. But now, with advancing technology and our more understanding, we have been evolved in a great way. And today, the expert faculties pan India will cover the very like a complex topics and will cover the intricacies of this fetal infection in pregnancy. We will be having how to screen for fetal infection, because we have taken this program today with the all queries and concern we share in various academic bodies, and we should screen or not for the routine cases, for the high risk cases, and how the imaging, how you are suddenly alarmed seeing ultrasound that something has gone wrong in between, some insult has been to the fetus. Dr. Geeta Balsarkar and Dr. Upma Saxena will cover all these 2 topics. Then the torch, which is sometimes the torch light is blowing, sometimes it is igniting, and we are many times confused, out of which the few infections are very important for the neonatal perspective. That is the CMV, herpes, and whenever there are evolving virus like Zika or the some new virus, we are actually lost. So Dr. Ashish, Dr. Saubhagya Jana, and Dr. Dasri Papa will cover the intricacies of whole torch range, what to do, and the neonatal issues. When the baby is born, what you have to communicate to neonatologists, how our communication can really help the neonatal care and optimize the neonatal outcome. So neonatal issues will be covered by Dr. Vijayanand Jamalpuri, and the vaccination in pregnancy, how like a few vaccines are there which can actually prevent the birth defect. So Dr. Parag, our own, the past chairperson, will cover that, and it will be followed by case-based discussion, how we encounter certain situations. That will be moderated by Dr. Vanda Bansal, and the eminent fetal medicine people from Pan India, Anita Kaur, Dr. Geeta Kolar will be expert with a galaxy of genetist and the general OB-GYN as well as the fetal medicine person. So we look forward to a great learning session, and it is a real great pleasure to invite first Dr. Sheila Mane, who is the chair ICOG and doing tremendous work like in last 2 or 3 months. So Dr. Sheila Mane, please we welcome you for your address. and then we will.
Yeah.
So Dr. Sheila Mane, yes.
Yeah. Thank you. Good evening, everybody. As we come to third day, we can see the enthusiasm. Already people have logged in, and I must appreciate the efforts of Dr. Sadhana Gupta and team for coming out with such a wonderful program. And I think this was a very, very useful even day-to-day practice. So not much to say. Everybody has already elaborated on everything. I would just like to say that please spread this news whenever you get it in your society groups. Okay, so we do try to send these flyers to the president and secretaries, but in case, and those who have logged in, if you are from a particular society, you share it in your society group so that more and more people will be aware. I think that is how we can spread the message and see that we are spreading knowledge across the country. So once again, thank you, and I wish all the best for today's program, and let us go ahead with the program.
Thank you, Dr. Sheila. Dr. Sarita Bhalerao, who is Vice Chair-elect and has done a very, very tremendous inning as a Secretary of ICOG. She is consultant OB-GYN at the many prestigious hospitals. So we invite Dr. Sarita Bhalerao for her welcome address.
Thank you, madam, and thank you for inviting me to welcome you. I welcome you all to this last day of this FOGSI ICOG course on infections in pregnancy. Big congratulations to Dr. Sheila Mane for the spearheading all these academic activities for this year, and to Dr. Pratik Tambe, Secretary, who's also working very, very hard. My congratulations to Dr. Sadhana Gupta. I can see that this is a very beautifully curated course. Very careful. All the subtopics have been very carefully selected. And the co-conveners, Dr. Pratibha Singh, Dr. Achala Batra, and Dr. Shashibala have done a great job, along with the coordinators, Dr. Mausumi, Dr. Kanchan Prasad, and Dr. Amrita. So I think that this has been a great 2 days, and I'm sure this evening is going to also really keep us all very fascinated. So wish you all the very best. Thank you.
Thank you, Dr. Sarita. Thank you for your gracious presence as well as the words of inspiration and appreciation. I invite now Dr. Pratik Tambe for his comments and his the words of wisdom. Pratik.
So good afternoon, everybody. I am live from the FOGSI office today for a change, and let me begin by expressing my sincere gratitude to everybody who's made this 3-day course such a stupendous mammoth effort. Beyond belief that we could have more than 1,400 registrations. We've had live audience of more than 650 at one point in time. Even today, I can see that there are 200 people logged in already, even before the scientific proceedings start. So I think this puts into perspective the importance of ICOG and academics. And I would like to also express my gratitude to all the coordinators, the conveners, Dr. Sadhana Gupta, and the entire team for putting together such a meticulously curated, fabulous scientific program, which is won so many accolades from lay persons, lay gynecologists. We get every day, both Dr. Sheila Mane and myself, and I'm sure Dr. Sadhana Gupta is also getting these personal messages late into the night, expressing gratitude for addressing some obscure thing. Yesterday, we had the new guideline of 2026 for sepsis and intensive care, which was highlighted, and many people wanted those guidelines as well. We'll try and share as many of those as possible on the website, and of course, the course proceedings for those of you who may have lost out on seeing certain lectures or you may have missed the first day. These will be uploaded to the website after a couple of weeks. So I wish you all the very best. Thank you very much to the entire team for putting in this mammoth effort. And I'm sure your efforts are appreciated by each and every single delegate. Thank you very much.
Thank you, Pratik. You are always an anchor and a big support because you are in Mumbai and you are there in FOGSI office. And we really appreciate that you share all the positive feedback that makes us moving. So we straight away go to the scientific session, and I request that Dr. Shashibala Bhonsle and Dr. Amrita Jaipuriar Amrita, you start the first scientific session.
Madam, shall I have to tell about the post-test details right now? Delhi
Yes,
instructions?
you can say.
Yeah.
Briefly, yes.
Yeah. Instruction to all participants about the post-test, that is the MCQ test at the end. Delegates of FOGSI ICOG online course, we have designed. Attendance for all 3 days course is compulsory. Google link for MCQs will be sent in the chat box. Those who have attended all 3-day courses and passed with 50% marks on each day, they only will get the certificate from ICOG. Certificates will be sent within 1 month. Please note that this online course certificate is just an acknowledgement of attendance. Practice depends on skill and experience, which we do not certify. So we do not endorse any skills of the attendees. The videos will be put on ICOG website in due course. For course material and equipment details, you may communicate with the course coordinators. So thank you, Sheila Mani madam, Sadhana Gupta madam, and Pratik and Sarita Bhalerao madam. Now I'll request coordinator Amrita Jaipuria to carry the session forward. Over to you. Amrita, are you there?
I've sent you an
Yes,
unmute
ma'am.
request.
Yes, ma'am.
Yeah.
Good evening, everybody. Thank you, Shashibala, ma'am. And a hearty welcome to the 3rd episode of the certification course of ICOG. The topic or subject being infections in pregnancy. Today, we have highly decorated and illustrious faculty as chairpersons and as speakers both. And we are discussing today fetal infections and continue it with the issues in neonatal period. So, coming to the first session, I invite the chairpersons, Dr. Smita Dhengle ma'am. She heads the Department of Fetal Medicine at her hospital, Bhopal. She is a faculty of ultrasound courses, West Zone Coordinator of Genetic and Fetal Medicine Committee, FOGSI. Welcome, ma'am. Second chairperson is Dr. Mala Srivastava, Director of Gynae Oncology, Professor, Ganga Ram Institute, Gynae Endoscopic and Robotic Surgeon, Sir Ganga Ram Hospital, and Chairperson of Clinical Research Committee of FOGSI. Welcome, ma'am. Our third chairperson is Dr. Anju Jain, Director, Jain Hospital, Varanasi, achiever of many awards, many publications to her credit, LLB and PG diploma in medical law and ethics. So, welcome and over to chairpersons. And I would request Dr. Mala Srivastava to introduce our first speaker, Dr. Geeta Balsarkar, and her topic is screening for fetal infections, confusions to clarity. Over to you, ma'am. Dr. Mala.
Thank you, Dr. Amrita. Good evening, everyone. It's my pleasure and privilege to be a part of this ICOG course. And also, it's my privilege to introduce the first speaker of the day, none other than Dr. Geeta Balsarkar, madam. She is the professor and unit head, Neurology, Wadia Maternity Hospital and St. G.S. Medical College, Mumbai. Honorary Consultant, Tata Memorial Hospital, Mumbai. She has been the editor emeritus, Jogi, Editor-in-Chief, International Journal of Infertility and Fetal Medicine, Vice President of Mumbai Obs and Gynae Society, Vice President-elect ISOPA from West Zone, President Association of Medical Women Branch, and President Menopause Society. Over to you, Dr. Geeta, for your scientific deliberation on screening for fetal infection, confusion to clarity.
Thank you, Dr. Mala Srivastava. And the topic that has been given to me today is screening for fetal infection, confusion to clarity. Well, I can tell you, even after 30 years of practice, still there is a lot of confusion when it comes to this topic, especially of fetal infection. So, which are the pregnancy-related infections where we are going to deal sometimes with the continuum of the fetal infections like chorioamnionitis, puerperal sepsis,
Your voice is
chorioamnionitis,
breaking.
puerperal sepsis.
Geeta, your voice is not clear.
My voice is not clear.
Your voice. Now it is better.
Yeah, so chorioamnionitis can be puerperal sepsis, septic abortion, episiotomy infection, pelvic septic thrombophlebitis. All these pregnancy-related infections can also affect the baby. There are non-pregnancy related infections like which have increased predisposition in pregnancy, like urinary tract infection, malaria, viral hepatitis, varicella pneumonia. In Mumbai now, especially, there is an outbreak of varicella, and lot of patients are coming with varicella pneumonia. So infection which is incidental to pregnancy, like community acquired pneumonia, which can be bacterial, fungal, viral, HIV, toxoplasmosis, cytomegalovirus, appendicitis, cholecystitis, and disseminated herpes. So when we as an obstetrician are dealing with all these infection, we have to see the benefit versus the choice of how we are going to deal with the mother as well as the baby. We are dealing with two lives here. We know that there is an increasing choice for delivering these patients to reduce the severity and have a less invasive treatment, reduce incidence of complication and death. At the same time, we have to see that we do not induce iatrogenic prematurity in the baby, or there is no increased sepsis in the baby. So this is a very delicate balance that we have to deal with. We are seeing these patients in a day-to-day practice. Every day we are dealing with this. So what are the concerns based on clinical findings? Whenever there is intrauterine growth restrictions, microcephaly, mother has hepatosplenomegaly with jaundice, congenital heart defects, if there's any rash, petechiae, unexplained thrombocytopenia, seizures in the mother, cataracts, sensorineural hearing loss, hydrops fetalis, these are the babies in whom we have to suspect intrauterine infection based on the maternal antenatal screening results obtained during pregnancy. When maternal findings are not suggestive, suspicion may arise that about certain clinical signs in the newborn. So what do we do with these patients? We have to do an initial clinical review. The evaluation of a newborn presenting with signs of intrauterine infection can be guided with clinical features. Like if you review the maternal history, we have to see the serology status, signs and symptoms of any of the antenatal infection, exposure to infectious sources, full physical examination for the other features which are consistent with infection, the blood reports, the full blood count, platelets, liver function test. If at all the mother is having severe infection, lumbar puncture, hearing test, ophthalmology assessment, radiology, neuroimaging, and x-rays of bone. We will have to do all these evaluation in the mother to be able to find out what sort of infection is there and how much the transmission is going to be there for the fetus. So if we see the whole big list, I'm sorry for the small fonts. I'm not sure if you are able to see, but there are a lot of congenital infections like CMV infection, HIV, hepatitis B, parvovirus, varicella zoster, rubella, treponema pallida, microbacterium tuberculosis, toxoplasmosis. These are the infections. So they can be classified as viruses, they can be classified as bacteria, and they can be classified as protozoa. So depending on the time of acquisition, they can be either antenatally, intranatally, or postnatally. And we should know what is a mother's immunity before we know what is the manifestation at birth and what is the treatment and prevention of this particular infection to the next baby. So what are the diseases? Like we are dealing with influenza. So influenza virus type A, B, and C, which are airborne infections, respiratory tract infections, throat, lungs. Like we saw COVID-19, measles, mumps, rubella, chickenpox, smallpox, which is more or less eradicated, polio, hepatitis A, B, and C, dengue, chikungunya, Zika virus, rabies, AIDS. These are all the infections of the viruses that we are dealing with. Depending on the mode of transmission, we will have to see what will be the affection in the baby and how best, along with the neonatologist, we can deal with these. So like I said, the infection can be prenatal or antenatal, it can be perinatal or intrapartum, and it can be postnatal. So examples of prenatal infection are cytomegalovirus, Zika virus, parvovirus, varicella zoster, rubella, the HIV virus, the hepatitis virus BC, whereas the perinatal are herpes simplex virus, HIV, hepatitis B, C, varicella, cytomegalovirus, adenovirus. These are all the intrapartum or the perinatal infections and the postpartum infections that can occur in the form of cytomegalovirus, varicella,
Geeta, you can
hepatitis,
try
etc.
switching off
These
your
are the
video.
three
Maybe
various
it will
forms of
improve.
infection.
In between it breaks.
These are the other types of infection. So the transmission routes for the congenital and neonatal infection, like what happens when a mother gets an infection, either there can be a hematogenous spread to the fetus, that is, which will result in an all or none phenomenon. So there will be miscarriage, abortion, stillbirth, IUGR, and congenital malformations. Suppose it is in transuterine and during the birth canal or during the birth, it can cause acute neonatal infections like acute disease, or it can be asymptomatic or can give rise to a late sequelae. The same about breastfeeding, or there can be even environmental associated infections that we can see at a slightly bigger newborn. So if we see, depending on the timing, it can be either gestational or during labor and delivery or puerperium. The various infections that can affect the mother and what happens to the fetus is shown in this particular slide. There can be bacteriuria, there can be pyelonephritis, there can be pneumonia, influenza, hepatitis, septic abortion, cytomegalovirus, rubella, syphilis, listeria, herpes, streptococcus, yeast infections, gonorrhea, or during the labor and delivery, we can have gonorrhea, yeast, herpes, and the puerperium, there can be mycoplasma and puerperal sepsis, all of which have varying effects on the fetus. Now, how do you screen? Screening for fetal infection is a very critical part of the prenatal care. It is used to manage infections that could potentially harm a developing baby. The process involves around a combination of maternal blood test and targeted ultrasound. And if needed, if we find something on the ultrasound, then we can advise an invasive diagnostic procedure. So when is screening recommended? At the initial prenatal visit or the first prenatal visit, routine screening for HIV, syphilis, hepatitis is very standard. Or during any time during the pregnancy, if the mother becomes symptomatic, if a pregnant person develops a rash, fever, known exposure to an infectious disease, then we'll have to investigate the patient at that particular time. Or any abnormal ultrasound finding, if routine scans show potential signs of fetal or developmental issues, then we will have to go back and investigate the mother for the infections. So if we categorize the intrauterine infection, there can be mild infection, there can be moderate infection, or there can be severe infection. Mild infections usually have good prognosis. We can do expectant management. Moderate has got very uncertain prognosis. Sometimes you may have to resort to antiretroviral therapy or a therapy for the infection. And in severe infection, there can be poor prognosis. Sometimes if they are less than 24 weeks, we could even have to consider the termination of pregnancy. So which are the various ways in which the infection can go from the mother to the baby? There can be transplacental infection because of placental disruption or fetal-maternal hemorrhage. There can be transmission of the infection across the fetal membranes. There can be ascending infection. There can be sexual transmission, or from the mother, there can be maternal impact. There can be placental impact, or there can be a growth impact or the fetal impact. So these are the effects of these particular infection. There can be some symptoms in the mother: inflammatory response, sepsis, respiratory distress, obstetric hemorrhage, or it could be affect the placenta, preterm labor, abruption, or it could have a fetal effect, like there can be birth defects, blindness, deafness, microcephaly, bone marrow suppression, fetal demise, growth restriction. These can be seen on the fetuses. So the mechanism, they say, is either because of the physical defenses which is lacking in this particular patient, or there is constitutive release of the effectors because of which they are not able to limit the infection, or the innate immune response of the mother which is less, therefore it makes her more prone for particular infections. So if you come to the background, the infection of the developing fetus or newborn that can occur in utero during delivery or birth is known as a perinatal infection. The complications include preterm birth, delayed development of the fetus, physical malformation or loss of pregnancy. Symptoms in the mother: fever, lethargy, cataract, jaundice, any rash, hepatosplenomegaly, heart disease. Or the baby can have microcephaly, reduced birth weight, hearing loss, blueberry muffin rash. So other examples are the torch infections like Toxoplasma gondii, the rubella, cytomegalovirus, herpes infection. The transmission is transmitted to the fetus through the placenta, or the infant may catch it while passing through the birth canal, or the mother can pass the infection infection to the infant through the breast milk. So there are lot of debate which are going on about which patients should be investigated for the torch infections. So this in short deals with congenital toxoplasmosis, syphilis, rubella, cytomegalovirus, and the herpes simplex virus, wherein they say that only those patients who have either symptoms or they have ultrasound features which show any of these patients should be investigated other for the torch infections. What is very important when we treat patients for torch infection, it is the titers have to be seen in paired sera. If you see those circles that are made in red, it is paired sera, and this will help us to know the timing of the infection. And serology are the maternal venous blood, cord blood from the fetus, neonatal heel prick blood, or dried blood spots. For PCR, we can use amniotic fluid, urine, nasopharyngeal swab, CSF, and saliva can also be used. What we need early and proper diagnosis will help us make proper decision and treat the fetus or the neonate wherever it is possible. So we have seen all natal testing that is possible, the non-invasive prenatal testing, embryonic villus sampling, the chordocentesis or the amniocentesis that can be done to detect the infection in the fetus. So either we know that it is a recent infection, the previous infection, or it is a non-immune reaction, or sometimes it can be false positive or congenital infection actually which has increased over the pregnancy period of time. So these are the various forms of infection that are seen. So if there is a primary infection, that is preconception immunity is there, then in about 30% of the fetuses only will get infected. Rest of the 90% will remain uninfected. And depending on the rate of uterine transmission, we can say with the outcome of the infection will be there. So 10% of the newborn will have symptoms, 90% of the newborn will not have symptoms, and similarly 10% will have severe disease and 90% will be without any disease, even in those patients in whom there is increase in titers. So the if we see ultrasound, if there are severe cerebral symptoms, or if there are no symptoms, or there are extracerebral symptoms, then accordingly we will have to investigate this patient. We'll have to go back and to investigate the fetus as well as investigate the mother if she has got any infection, viral infection during the course of the pregnancy. So ultrasound diagnosis of hydrops fetalis, sometimes it is an emergency. We have to look at the maternal blood sample and the fetal ultrasound examination, and if there is fetal anemia or no. And if there is fetal anemia, we will have to urgently give, especially in parvovirus B19 infection, we will have to give the pack cell volume to the fetus. So there are various complications because of the perinatal infections. It can be pregnancy related complications, fetal and neonatal complications, or long-term health issues, both for the mother as well as the baby. So congenital infections manifest as growth retardation, low birth weight, malformations, or any fetal loss or stillbirths if it has been there. Postnatal infection, they will show meningitis, septicemia, conjunctivitis, pneumonitis, or there can be perinatal infections which can occur as a baby passes during the delivery in the vaginal tract. So what is very, very important is we have to educate the common public as well as the mothers. So this what have shown is a WHO, which is a passive screening for infection prevention and control for the patients as well as the visitors in the hospital. We can put this up. This is a WHO thing, so we can put it up in our hospital. Please inform if you have unexplained rash or lesions on your body, new or worsening diarrhea, cough, shortness of breath, running nose, fever, and chills. And please don't visit patient in the hospital if you have got any of these. So there is an attention to staff who are working in the hospital as well as visitors. Fever, sore throat, nausea, cough. Please do not come and visit our patients and children and make them susceptible for infection. This is taken from the WHO website, and we can display so that we can educate the patients as well as the relatives about the perinatal infections. So this is my book on Manual of Perinatal Infection, edited by me along with Dr. Vandana Valvekar and Jassawala as early as 2015. So this has got completely everything about the investigation, the management, and the differential diagnosis of perinatal infection. Thank you for a very patient hearing.
Thank you, ma'am. Thank you, Geeta ma'am, for a wonderful talk. And Sheila Mane ma'am, you are muted.
Yeah. Excellent talk. Okay, I know the topic is very vast. Okay, Amrita, you can go ahead.
Okay, any questions now, or should we move to the next talk, ma'am?
We take the questions in the chat box, please.
Amrita, you invite chairperson for their
Okay.
comment and the introduction of next speaker.
Okay.
The questions will be in the chat box because we are very, very time sensitive.
Okay.
Yes, so invite
So
the
may I request the chairpersons to give their comments on this talk?
Excellent talk,
Yes.
Dr. Geeta. It's actually a very vast topic, but we have to be very sensitized about how to take care of our antenatal patients while they're having rashes, while they're having fever, and how do we investigate them and how do we protect them from complications of the fetus as well as of the mother. Rightly said, we are looking after 2 patients at a time. So our decisions, our investigation, our management have to be very carefully targeted and very carefully focused. Thanks for elaborate scientific deliberation on fetal infections during pregnancy.
It was
And-
really excellent talk, and I must say that especially the torch, it is very much overrated investigation, but we all should be stressing upon what is the indication, as the next topic will also include that. And Madam has beautifully put that the paired sera is to be taken, and what is the indication that we should be suspecting it, and when should we following up that mother. So fetal infection, a very important part, especially we fetal medicine people are looking into it and how to follow up that. Excellent talk, very well described. Thank you so much, Geeta ma'am.
Thank you, chairpersons, for your inputs. And may I now request Dr. Smita ma'am to invite our next speaker, Dr. Upma Saxena, and introduce her. Over to you, Smita ma'am.
Yes, just give me a second, please. So next, I invite Dr. Upma Saxena.
Yes.
She's going to give us a talk about imaging on fetal infection. And I must say, a very close to heart a topic for us, the fetal medicine people, because day in and out we are trying to save each and every fetus. And Dr. Upma Saxena, she is currently she's holding the positions of in charge of faculty fetal medicine and genetic clinic, and she has over 3 decades of teaching experience. I mean, she doesn't need any introduction for any of us. I mean, directly we should be going over to listening to her wisdom pearls and what she has to add to the topic, I would say. So let's get on to the talk, I would say.
Thank you, Dr. Geeta, for the kind words. Shall I share my slide?
Yes, please. Yes, please.
Can you see it?
Yes, it is visible.
Yes, we can see.
Yeah. I'm making it full screen.
Full screen, please.
Yeah, is full screen?
Yes, it is seen.
So good evening. At the outset, I want to thank the ICOG for giving me the opportunity. And and good evening to all chairperson and dear friends and colleagues. I'll be talking about imaging in fetal infections. TORCH are the group of infections with similar presentation, and ultrasound and MRI are the key diagnostic modality. In some, the initial finding of abnormal ultrasound feature may trigger testing for congenital infection. In other, either maternal serology or symptomatology may lead to targeted ultrasound. Once infection is diagnosed, imaging modality can also be used for follow-up to determine the fetal prognosis and to guide further investigations and management. As Dr. Geeta has already told, now we knew the new terminology, SCORCH, which also includes syphilis and chickenpox. And TORCH infection attributes to 2 to 3% of all congenital anomalies. HSV rarely cause fetal infection. So as you can see here, most of them cause fetal growth restriction. Anomalies are mainly cardiac anomalies caused by rubella, and the parvovirus leads to fetal anemia and high drops, and CMV causes majority of the perinatal infections. So we all are aware that there's we do transaxial view of the brain, which is a standard ultrasound plane, and it includes transventricular view, transthalamic view, and transcerebral view. Whenever a diagnosis of ventriculomegaly is made on transventricular view, then it becomes an indication for doing a detailed neurosonography, because cerebral signs are the most important prognostic indicator of fetal infections. So neurosonography, beside including the 3 axial views, also includes 4 coronal views from anterior to posterior, which are transfrontal, transcaudate, transthalamic, and transcerebellar, and sagittal views, which include 1 mid-sag view and 2 lateral views, which in right and left lateral views. So MRI is done when ultrasound results are inconclusive, and it is considered safe because there is no ionizing radiation. It is also done in case of ventriculomegaly because it gives additional finding in almost 1 to 14%. So MRI can help us in diagnosing agenesis of corpus callosum, cortical malformation, and migration cerebral abnormalities which ultrasound can miss. And it also helps in assessing the extent of destructive injury in fetus with known infections. MRI should always be done after 32 weeks as milestones of CNS development become more evident. Should never be done before 26 weeks. And the specially beneficial with the MRI is to see the near hemisphere ventricles and anatomy, and also it helps us to differentiate gray matter and the white matter. It also overcomes problem due to obesity, difficult fetal position, advanced gestational age. It helps us to counsel couples who need more information on prognosis and outcome. So MRI gives us true multiplayer imaging with superior contrast resolution and large field of view with excellent visualization of CNS structure. It is advantageous over neurogram because it is better in diagnosing malformation of cortical development, migrational abnormalities, intraventricular hemorrhage, posterior fossa abnormality, and also help us in clinching the diagnosis of etiology of ventriculomegaly. So SFM, it says that it should be done after 32 weeks if the radiological interpretation facility is available. But it is of less value if already a detailed neurosonogram has been performed by an expert. So this ICOG has given the guidelines on the role of ultrasound in congenital infection in 2020. And ultrasound suggestive of congenital infections are cranial abnormality, extracranial abnormality, placental and amniotic fluid abnormality. So the cranial signs which we see are ventriculomegaly, intracranial calcification, periventricular echogenicity, periventricular calcification, polymicrogyria, intraventricular adhesion, megacystis cisterna magna, subependymal cyst, genesis of corpus callosum, and extracranial signs which we can see are cardiomegaly, splenomegaly, echogenic bowel, pleural effusion, fetal ascites, and placentomegaly. The presence of any of these ultrasound in fetus is not diagnostic, but merely suggestive of congenital infections such as CMV, toxo, rubella, varicella zoster, Zika, and should trigger testing for them. And if the fetus shows high drops of anemia, then we have to do testing for parvovirus. In CMV and toxo, the risk of fetal infection increases with gestational age maternal infection. However, earlier the gestation at which the infection occurs, greater the risk that the fetus will be affected. So once a maternal infection is diagnosed by serological testing, whether triggered by maternal symptoms, contact with another infected individual, or discovery of an ultrasound abnormality, the possibility of fetal infection should be contemplated, and a USG and MRI should be done to see the stigmata of fetal infection. Definite diagnosis, however, can be made only by doing the amniocentesis and doing a PCR, which should be done 6 to 8 weeks after the initial maternal infection and at about 18 to 20 weeks of gestation, because before that, fetal urination is not well established, so there is not sufficient concentration of the virus in the amniotic fluid. But confirmation of fetal infection does not necessarily mean that a fetus will be affected, because sometimes the fetus do not exhibit any imaging abnormality, then also they may have a long-term sequelae. Coming to CMV infection, it is a double-stranded DNA virus, and it is the commonest viral cause of congenital infection. So besides causing sensorineural hearing loss, it also causes FGR, and chorioretinitis. So the signs which we see in CMV infection could be in the CNS, cardiac, abdominal, and placenta. These are the commonest signs which we see in CMV infection. So the cranial features typical of CMV are megacisterna magna, intracranial calcification, cerebral calcification, periventricular cyst, subependymal cyst, intraventricular adhesion, germinolytic cyst, agenesis of corpus callosum. And in MRI, we can make a diagnosis of Leisen-Kefli or bald brain, which because of the severe infection. Extracranial signs typically seen in CMV are hepatosplenomegaly, cardiomegaly, pericardial infusion, echogenic bowel. And in placenta, we may see placentomegaly, placental calcification, which are suggestive of placenticitis, and this occur before the fetal infection. The LICA abnormality, which one can see, can be in the form of oligohydramnios and polyhydramnios. All these constitute soft marker for CMV infection. So, but the definite diagnosis can be only done by doing a CMV PCR test 8 weeks after the maternal infection and after 20 weeks of gestation. Neurosonogram and fetal brain MRI are complementary modality in the third trimester with a sensitivity of 95%. Normal brain findings are associated with low risk of infant disability. Fetal cerebral abnormalities are the main sonographic prognostic indicator for symptomatic fetal CMV infection. So ultrasound abnormality can appear as late as 12 weeks. So we have to follow them up 2 to 4 weekly. The combined predictive value of ultrasound and MRI after 30 weeks for an asymptomatic neonate is almost 95%. MRI has a high negative predictive value for sensorineural hearing loss and neurological impairment. But more than 50% of the infants will not show any stigmata. And according to this meta-analysis, these fetuses also 4.4% may have associated CNS anomaly on follow-up, and 6.5% may have hearing problems. Coming to congenital toxoplasmosis, which is caused by Toxoplasma gondii, which is an obligate intercellular parasite, and it leads to triad of hydrocephalus, intracranial calcification, and chorioretinitis. And if we see a combination of cerebral echogenic lesion and ventriculomegaly, then it could be there could be a chorioamnitis in the baby. So ultrasound follow-up should be done 4 weekly, focusing on fetal brain, ocular and growth assessment, and fetus and the mother should be counseled. Even if the fetus has no imaging abnormality, then also there is almost 30% chance of long-term sequelae in the form of chorioretinitis, which could lead to vision loss. Typical findings which we see are severe bilateral ventriculomegaly, echogenic thickened ventricular wall, hydrocephalus, intracranial calcification, dystrophic calcification in the junction between cortical and subcortical white matter with the enlargement of the subarachnoid space, hepatomegaly and ascites, and it could be liver calcification with placentomegaly. Coming to parvovirus or fifth disease, it is a single-stranded DNA and it is responsible for 1 to 2% of the infections. And here the chance of fetus being affected is more if the infection occurs before 20 weeks. After that, it is almost nil. In case of parvovirus, it causes fetal anemia leading to aplastic crisis, which occur up to 8 weeks of infection, and it can develop rapidly within 7 to 14 days. Typical finding which we can see on ultrasound are skin edema, ascites, cardiomegaly, pericardial effusion. So direct pleural or myocardial inflammation by the virus can also lead to the transient infusion, and the fetus may have cardiac failure and subsequent hydrophytosis because of fetal anemia associated with hepatitis, hypoalbuminemia, and myocarditis. Risk of fetal hydrops is low, but where it develops, almost 50% of them will lead to IUD. So amniotic fluid DNA PCR is a high sensitivity of 100%. Serial ultrasound with MCA PSV should start 4 weeks after the infection, and it should be performed every 1 to 2 weeks and should be continued for 12 weeks after the infection. When MCA PSV is more than 1.5 mom or there is fetal ascites or hydrops, then it is an indication for fetal blood sampling with preparation for intrauterine transfusion. If the fetus is non-hydropic, one transfusion is enough, but almost 1/3 of the fetus with hydrops will need 2 or more transfusions. So parents should be counseled that in case the baby is non-hydropic, then the perinatal death is just 6%, but it increases to almost 30% if the fetus becomes hydropic. So cerebral imaging should be considered in fetuses who are hydropic and with fetal anemia because they have the 10% sequelae of the 10% chance that they may have neurodevelopmental sequelae. Congenital varus zoster syndrome. It is a DNA virus of herpes virus, and 90% of the women are already immune to it. Again, in this, the risk of infection is only when when it occurs before the 20 weeks, and it is one of the indications for termination of pregnancy. Herpes zoster is not associated with fetal or perinatal harm. So typical signs which we see on the baby in the fetus is FGRs, cortical atrophy or microcephaly on CNS, polyhydramnios due to decreased fetal movement or digestive tract atresia, dermatological scarring, lip abnormalities, Ocular abnormalities such as cataract and microphthalmia and soft tissue calcification. So half of the fetuses who are infected will show either the ocular or limb abnormalities. Coming to congenital rubella syndrome, it is a single stranded RNA virus, and we all know about the triad of Gregg, where there's cataract, microphthalmia in the eye, pulmonary stenosis, patent ductus arteriosus in the heart, and there could be sensorineural hearing loss. And here, 90% of the fetuses are affected if it occurs before 12 weeks, and is also needs, usually the parents are counseled for termination of pregnancy. So the ultrasound finding which we can see are cataract and microphthalmia in the eye, congenital defect, microcephaly, ventriculomegaly in the CNS, hepatosplenomegaly, FGI, and stillbirth. And ultrasound has a specificity of 100% in diagnosing this. So ultrasound, we can see microphthalmia, ventriculomegaly, and periventricular calcification. Coming to congenital Zika virus, it is a flavivirus which is transmitted by Aedes mosquito, but it could be also sexually transmitted. And the treatment and the primary test is the reverse transcription PCR. And following maternal exposure to Zika virus, an assessment of fetal anatomy, including intracerebral abnormality and biometry, should be performed. And if the baseline scan is normal, a repeat scan should be done in the third trimester. If the infection occurs early, the risk of fetal infection and deformity is more, and option of termination of pregnancy can be discussed. Amniocentesis should be done after 20 weeks. And the women who have suspected Zika virus infection should be treated by an multidisciplinary team. There could be normal imaging finding, but then also the risk of developing the infection is very low. But these fetuses, these babies born should be followed for at least 12 months. So fetal abnormality which we can see are either cranial or extracranial. So according to this Lancet paper in 2017, the cerebral anomalies which we see in a Zika virus are microcephaly, overlap of parietal bones and abnormal gyration pattern, ventriculomegaly, atrophy of the cerebral mantle and enlarged pericerebral spaces. There could be subcortical and basal ganglia nuclei calcifications. There could be anomalies of corpus callosum, brainstem, and posterior carina fossa. Coming to congenital syphilis, the USG findings are seen only in the second half, that is after 20 weeks. And the typical findings are placentomegaly, growth restriction, hepatosplenomegaly, intrahepatic calcification, distorted fetal long bones, and ascites. And diagnostic invasive testing are not recommended. So we see a typical ultrasound finding which we see in these infected fetus are either hydrops, ventriculomegaly, or echogenic bowel. So to conclude, signs of fetal infection or ultrasound are ventriculomegaly, microcephaly calcifications, intraventricular synechiae, intracranial hemorrhage, periventricular cyst, cerebral hypoplasia, cortical abnormalities, hyperechogenic bowel. But all of them are not suggestive of congenital infection. They just suggest that the testing should be done. And if the baby has hydrops or anemia, then it becomes an indication for testing for parvovirus. CMV testing should be done if mother present with the mononucleus-like illness, which Dr. Geeta has just explained, and or there is signs of congenital fetal infection, which are suspected on abnormal ultrasound. DNA PCR of amniotic fluid at 18 to 20 weeks is the gold standard for diagnosis of the fetal infection. So thanks for the patient listening.
Thank you, ma'am. Thank you for a wonderful talk. And chairpersons are requested to conclude this session.
See, basically, very important point. From the advent of the neurosonogram, torch infections have gained a lot of importance because these neurosonograms, they are important findings. And if we had not done investigation by torch, we will not have any clue how to go about these patients and managing these patients. Dr. Upma, you have nicely touched all the imaging points which are important to diagnose typical fetal infections and how we can handle them and how can we guide the mother and give a healthy baby to her. Thanks for your nice and comprehensive, vast coverage of the topic that you have been discussing.
Thanks, Dr. Mala.
Smita ma'am,
Very
your comments,
nicely
please.
covered.
Yes,
Very
ma'am.
nicely covered topic. And ultrasound is mainstay, I would say, whenever we pick up any finding. But I must say that invasive testing and proving that fetal infection is there, that is important. And then follow-up is equally important. So a fetal medicine specialist has to be in this loop and the obstetrician and the fetal medicine person can definitely give you a good outcome for this pregnancy and this fetus.
I think counseling of these parents is the most difficult thing.
Most difficult part
Because
because
you are also not
outcome.
clear what to tell them.
Yes.
You see any cerebral abnormality and then you tell kids there will be no sensory neural, so it's difficult to counsel.
We can't say about that. But
You
if we
can't.
have done the priming, then at least they are ready to accept, or maybe they can have their decisions accordingly.
Yeah.
So thank you to the speakers and the chairpersons of the first session. Fabulous talks. I think there were some technical issues when Dr. Geeta was speaking, so apologies for that. Can we move on to the next session, please?
So the next session is Torch Revisited. And we have been talking about Torch since the first session started, but again, Torch is being revisited. And for this, I would like to invite the chairpersons, the very decorated Pragya Mishra Chaudhary Madam. She is the consultant infertility specialist at New Life Test Tube Baby Center and MGM Hospital and Research Center, Private Limited, Patna. She is the President, Patna Obs and Gynae Society 2526, Chairperson, Genetic and Fetal Medicine Committee, FOGSI, from 2016 to 2018. Welcome, ma'am. Our second chairperson is Dr. Kanjan Prasad, very dynamic, Professor, TMMC, Muradabad, North Zone Coordinator of Internal Exchange Committee and Clinical Research Committee. And she is also the editorial board member and reviewer of Index Journals. So over to chairpersons for Torch being revisited. May I invite Dr. Kanchan to introduce our first speaker, Dr. Ashish Kumar Mukhopadhyay,
Thank
and
you.
introduce him.
Thank you so much, Amrita ma'am, for the kind introduction. And also I want to thank all the office bearers, Sheila Mane ma'am, Sadhna ma'am, and Pratik Tambe sir for giving me opportunity to chair this important session. And I want to introduce, it's my privilege to introduce a speaker of this session, that is Dr. Ashish Kumar Mukhopadhyay sir. We all know sir very well. And sir is currently principal and professor and unit chief of Obs and Gynae at CSS College of Obstetrics and Gynae Child Health, Kolkata. Sir is a vice president FOGSI during 2016 to 17. Sir was GCM ICOG during 21-23. Past president Bengal Obs and Gynae Society, and sir has been on many prestigious posts. And we all know sir is a great academician. So it's a privilege to have you here, sir. Sir will be talking on toxoplasma and rubella. Welcome, sir.
Thank you, Kanchan. Respected chairpersons, am I audible now?
Yes, sir.
Can I share my screen now?
Please
Yes,
go ahead,
sir.
sir.
Can you see it?
Full screen, please.
Yes, it's okay, no? Actually,
Yes.
the Mac was giving some problems, so I have shifted to this Windows system. But my thanks go to Dr. Sheila Mane and Dr. Sadhana, my dear friend, Dr. Pratik, and all the coordinators of this program, respected chairpersons and the learned delegates, and the honored faculty members. It was a pleasure hearing and seeing those ultrasound images by Upma on toxoplasmosis, and that has actually made my job a bit easier. At the outset, I must tell you the importance of this discussion. We must be sure about this. And we all know that the maternal infections are innocuous, maybe asymptomatic, but approximately 2 to 3% of all congenital anomalies are attributed to perinatal infections. That is the importance. And also, the presentations are very diverse. It may be seen during the intrauterine period, at birth, in infancy, or maybe even years later in the form of abnormal growth or developmental anomalies. I was very upset when this real-life case came to me a few years ago, 26 years, para 0+1, with history of only one spontaneous abortion, was advised torch test at a peripheral antenatal clinic, one of my junior colleagues, 3 years ago after first abortion. Only Toxoplasma IgG was positive, rest all were negative. She was given spiramycin tablet 3 million international unit, 2 tablets twice daily for 3 weeks by her local gynecologist. She was told not to conceive till IgG was negative because of risk of congenital toxoplasmosis. And she underwent IgG for toxoplasmosis every 6 months rigorously, which was positive every time, and she continued to take OC pills for these 3 years. Won't you feel angry about this? Now, this is a situation in many of the centers. I can see also question in the chat box. What are the indications of toxoplasma test? Torch complex has been adequately defined by you, and O means others, which stands for syphilis, hepatitis B, by Treponema pallidum and hepatitis B virus. Come to toxoplasmosis. It's a zoonotic disease caused by a strict unicellular protozoan parasite, Toxoplasma gondii. It affects 1/3 of the total world population. So you can see the diversity of this infection. And it has got the widest host range worldwide. And that is the reason why there is a global distribution of the parasite. And not only that, it has caused a widespread concern. Come to that in a minute. But in the meantime, let us see what is the country prevalence rate here in India. Average prevalence rate is 20%, average. But it is highest in the women of the sub-Himalayan area, 77%. In the Eastern India population has 18%, and rest of the others you can see from here. Why it has created this widespread phobia? Because it affects 1/3 of the total world population. And that is a matter of major concern. At the outset, I must say that it is not a cause of recurrent abortion. The most important myth associated with TORCH is that it causes recurrent abortion, which doesn't. Why, I will explain. Only pregnant women with primary active infection with Toxoplasma gondii during pregnancy will lead to congenital toxoplasmosis. And after primary infection, there's a persistence of cysts of tox. I will explain the cysts. But development of the active immunity protects all subsequent pregnancies. So there is no need to panic in subsequent pregnancies once it has happened in a woman's lifetime in the reproductive age during pregnancy. Now, it's very rare to have a reactivation of the primary infection, and that is possible in cases where there is immunosuppression, like people on chemotherapy, congenital immune deficiencies, AIDS or HIV, long administration of corticosteroid drugs, like in transplant patients. Apart from these exceptions, it's very, very, very rare to have infection later on in life. Some discussion on cats, very important for toxoplasmosis. Cats are the only animal species to shed the infectious stage in their feces, and commonest of them are oocysts. And cats get it. How do they get it? By eating rodents, raw meat, cockroaches, flies, or by contacting infected cats, infected cat species, or contaminated soil. However, all animals can disseminate toxoplasmosis when you eat them, either half-cooked or uncooked. And that is the reason why many animals can spread toxoplasmosis, but cats are unique in this position. Why? In the cats, the parasite exists in 3 forms. One is the oocyst we already described, which releases the sporozoites. And there is another concept known as a pseudocyst. Pseudocyst or infected cells, they look like a cyst, they're not cyst actually. There it is tachyzoids. And the tissue is cyst, which releases bradyzoids. So there are 3 things out here: oocysts, commonest, tachyzoids, and bradyzoids. Cats shed oocysts after they ingest any of the 3 forms. So they will take bradyzoids also, tachyzoids also, and they will shed oocysts for the transmission. After an intraepithelial cycle, possible only in the small intestine of members of the cat family. So that's very specific and unique about toxoplasmosis in the cats. The oocysts are excreted in the feces for a period of 1 to 3 weeks, prolonged, and as many as 10 million may be shed in the feces in a single day. The oocysts may remain viable for up to 18 months in the warm and moist soils prevalent in tropical countries. So they actually encourage disease. So the oocysts, they are the chief infective forms. The oocysts are killed at refrigerated temperature and almost instantly at temperature of 67 degrees Celsius. Tachyzoids are hallmark of active infection and can invade any nucleated cell. Thus, the Toxoplasma gondii can cause infection of any organ in the body. That is why it is so widespread. And bradyzoids, they persist. They're hidden in different tissues for a long period of time and give rise to infectious exacerbation whenever the immunity is low. So they normally remain silent, but they wake up in face of any immunosuppression. Epidemiology, one-off infection which produces a long-lasting immunity, as I said. Therefore, chronic toxoplasmosis is the concept which does not exist in immunocompetent individuals. However, the matter is different in a case of immunocompromised individual that we have discussed before. And only a primary infection during pregnancy can cause fetal infection. So there is no possibility of fetal infection apart from a primary infection during pregnancy. Pathogenesis is very interesting. The sporozoites that are released from the oocysts or bradyzoids, they release from the tissues, multiply in the intestinal epithelial cells of the macrophages at the site of entry. And the tachyzoids multiply within the macrophages, spread to the mesenteric and then to other lymph nodes, and thence to distant organs of the reticular endothelial system. That is the mode of spread. Destruction of the host cells occurs due to the rupture of the infected cells, which may also be caused by hypersensitivity reactions. This is especially damaging for the cells which are not regenerated, like muscle cells, CNS, and the retina. And hence the effect which we have seen beautifully in the images by ultrasound, which just seen. Come to the transmission. Transmission of the disease in adults is mainly by ingestion of the food or water contaminated with oocysts, or by ingestion of the raw or uncooked meat. So both are the transmitting agents. Toxoplasma gondii has a unique characteristic of to infect human beings through any possible route of infection, like oral, parenteral, transplacental, respiratory, and through blood transfusion. You name it and you have it, and organ transplants also. On the other hand, the rubella, which are my second topic, is transmitted to the mother by droplet aerosols and to the fetus through the placenta. And congenital infection occurs from the transplacental passage of the parasite from mother to fetus in both cases. Through the undercooked meat, as I already talked about, the order is pork, chicken, beef, and any meat. This is of no interest to the vegetarians or vegans, but to the non-vegetarians, this is of interest. And human-to-human transmission is not possible except transplacental, of course. Tissue cyst in a man is a dead end for the parasite. So that is the end. When the tissue ends, the parasite enters the human body, it's actually death for the parasite. Well, clinical picture in the mother is difficult diagnosis because majority of the infections are mild, asymptomatic, self-limiting, and may go unnoticed even. There are only 10 to 20% of cases, a minority of them will present with specific symptoms like generalized toxoplasmosis, flu-like disease, fever, fatigue, weakness, malaise, or a lymphatic toxoplasmosis, fever with generalized lymphadenopathy, cervical, retroperitoneal, mesenteric, abdominal pain, lumbar, occipital, liver, and spleen enlargement. There can be a neurological toxoplasmosis whereby we find encephalopathy and chorioretinitis. We can have an exanthematous toxoplasmosis, a huge amount of rash, maculopapular, and ocular toxoplasmosis, like causing eye pain, photophobia, blurred vision, scotoma, chorioretinitis, retinitis, and blindness. But these are all rare. The commonest thing is that they are asymptomatic and sometimes may go unnoticed also. In the fetus, as I already said, only primary infection. The transmission risk in the first trimester is 15%. Second trimester is 25%. The third trimester is 65%. So numerically, third trimester is much superior. But the infections are most severe when they are contracted in the first trimester, although it is only 15% in prevalence. The overall frequency of subclinical infection in the newborn baby with congenital toxoplasmosis is as high as 75%. So there also we suffer from diagnosis loss. In 25% of the infants, common symptoms are mental retardation, seizure, hepatosplenomegaly, CNS, and eye involvement. The so-called oft-quoted classical triad of hydrocephalus, intracranial lesion, calcification, and chorioretinitis is extremely rare, although we have discussed it quite elaborately. Now, this is the picture which shows actually how the human exposure happens and how the cats, they ingest it, they convert into oocysts, etc., etc. So I have already discussed all these things. This is schematic representation. And this is the slide borrowed from Professor Arul Kumaran. It shows exactly and nicely how the trimester-wise affection of the fetus, affection of the severe disease at birth, or ocular sequelae in later life happens. And look at this, looks like in inverted pyramid, the first two pyramids of the fetal infection and the severe disease at birth, but it is very high for the ocular sequelae in later life. So we have to be very careful about the third one. These are the recipes for possible infection, and uncooked meat and half-cooked meat or the rest of our foods we are susceptible to toxoplasma. And you never know when it has entered your body. Active infection normally occurs only once in a lifetime. That's enough. It generally is harmless and inactive unless the human immune system is not functioning properly. If a woman develops immunity to the infection at least 6 to 9 months before pregnancy, there rarely is any danger of passing it on to the baby because immunity is developed to it. This has got an important corollary, and I will put that advice in the end. This is the pattern of the IgG and IgM, which happens during the infection. The x-axis shows the time after initial exposure, and the y-axis shows the immune response. As you can see that the IgG is running very high. It has got a constant elevation of bulge up to the point, and thereafter it remains quite high. And remember, this titer of this IgG is extremely important in determining infection, whether it is active or passive. IgM runs a bit low, but it disappears quickly after some time. So I think IgM is reliable only for certain cases of diagnosis. Now, a lot of time has been spent on screening, and elaborate discussion has been done on ultrasound. So I think we will focus on the diagnosis with serodiagnosis. If you are lucky, we will get cervical lymphadenopathy or a mononucleus-like infection, but it diagnosed by rising titer of IgG antibodies. So this is very, very important. Done 3 weeks apart along with IgM rise. So 2 things you require. One is the IgM rise, another is the rising titer of IgG antibodies. And the single elevated IgM titer are unreliable as levels remain elevated for 12 months. You cannot make out anything from there. And also elevated IgG levels indicate a past infection, robust immunity, and no risk to the fetus, almost no risk to the fetus. So the diagnosis is basically morphologic, and which is difficult. Like you can find out the tachyzoids in circulating WBC, bone marrow, lung, spleen, brain, or by histopathological examination. So that is actually out of question. Then culture of the animal, cultural animal inoculation also very rare. So we are mainly depending on the serologic diagnosis, and that's what I want to highlight. Detection of parasite genetic material by PCR, especially in the detecting congenital infections in utero. So the serological diagnosis is the most widely used test for the measurement of IgG, ELISA, DAT, or IFA. Normally, IgM and IgG rise simultaneously. IgG persists for years, and IgM undetectable after cure in most HIV patients. So both IgG and IgM are necessary for the diagnosis, but the IgG rise and IgM rise, even if though happen simultaneously, but IgM will quickly subside after a very period of time. So elevated IgM titer is diagnostic of recent infection in persons with normal immunity, and disseminated infection may exist in AIDS patients without demonstrable antibody titer. So this is the rough sketch of the approach to the toxoplasma serology. If you get an IgG and IgM both negative, it excludes current or past infection, counsel patient about future risk, of course, by the exposure, and both should be positive if acutely infected. So acute infection means both are positive. But that window is important because in a small window, IgM will be positive, but it will come down. If IgG is positive, do an IgM test immediately. A IgM test confirms positive acute toxoplasmosis or current toxoplasma infection, but the quality of the test kit is very important. IgG plus, IgM minus, IgM negative, that means past infection, no risk to the fetus, no further testing is necessary. And IgG negative, IgM positive may have a current infection. Mind the word may. Repeat serology in 3 weeks. If IgG turns positive, recent infection is confirmed. Now, somebody was questioning about avidity test in the chat box I saw. What is avidity basically? Avidity may be defined as a functional affinity. Avidity test is an estimation of the overall strength of the antigen-antibody bonds. So you determine the strength of the antigen-antibody bond. In general, IgG antibodies exhibit high functional affinity. So there's no problem about that. But proportion of highly avid IgG increases after immunization also. So you have to take care of that. In IgM positive patients, the near exact time of the infection can be estimated by avidity. So as I said, IgM stays for a shorter period of time. IgM, if it is positive, if you can have the scope of avidity test, that will determine the near exact time of infection. That is the advantage of avidity test. Hence, in beginning, the antibodies with low affinity are produced, and as the time passes, the IgG with high affinity or avidity increases. However, low avidity is not an absolute indicator of recent infection. That is also true. So what are the cases where you should examine this? There was a question in the chat box also. Index of suspicion should be high. Where? IUD or abortion. Remember, not recurrent pregnancy loss, prematurity, rupture of membrane or leakage or fetal distress of preterm labor, maternal fever and illness, HIV positive, and other conditions, bone marrow transplant, etc., etc. This is the scheme of diagram which I've already mentioned. You can put a scheme like this in your OPD so that you can have a quick diagnosis and then serological diagnosis. For the treatment, no treatment in asymptomatic because it is self-limiting except in children to prevent retinal inflammation disease. Treatment of pregnant women is controversial because of toxicity of the medication, but is still advocated. What is the drug? The drugs are, one is pyramycin, rubomycin, 5 times more concentrated in placenta than maternal serum and passes through the pituplacental barrier, and therefore it prevents fetal infection in 95% of cases. So very good for preventing neonatal infection. Daily for rest of the pregnancy, 3 gram daily in divided doses, or 3 weeks treatment, then 1 week rest, or 1 week treatment, then 1 week rest, etc. Many such regimes are in practice. I think people have developed their own choice, but the commonest is daily for rest of the pregnancy, 3 gram daily in divided doses. Now,
sorry to interrupt you, sir. Your
Sorry.
time.
Yes, sir.
Yes. I'm just coming to an end in 2 minutes' time. When fetal infection is confirmed by prenatal test after 20 weeks, a combination therapy is recommended. This is for the fetal infection. And the combinations are pyrimethamine and sulfadiazine or pyrimethamine and clindamycin. Now, prenatal diagnosis is very, very important. Ultrasonography has been adequately demonstrated. So I'm not going into that anymore. And the suggestive findings are also discussed. Now, invasive diagnosis by amniocentesis, by chordocentesis, or from umbilical cord blood after delivery, CVS is not helpful. And there are some newer tests which are not advocated this time. And antenatal screening was already discussed. Management scheme is mother infected but fetus not infected, pyramycin. Baby born with symptoms and no symptoms, pediatric examination, and then cord blood and placental examination. Infected, treat baby for 1 year, and IgG every 2 months for the baby. Pyramycin is a macrolide antibiotic, nothing beyond that. I'm not going to discuss in detail because of lack of time. Dosage and administration are already mentioned. This is the protocol which I've mentioned. Now, there are some other options management options I must mention, that cook the meat thoroughly. Do not have meat outside. Freezing in household freezer for 1 day kills toxoplasmosis. Wash hands and utensils thoroughly. Washing fruits and vegetables properly. Wearing gloves while handling soil or cat fishes, not to feed raw meat or cat fishes. In rubella, just I'll have 2-3 slides, not more than that. A mild self-limiting disease with prodromal symptoms mainly causes polyarthritis and arthralgias, and the risk of congenital rubella syndrome is there. The vertical transmission happens in the first trimester after 36 weeks also. So acute rubella syndrome is a clearly defined concept syndrome. It has IgM serology as the initial diagnostic test due to its availability and low cost. It's the first test. Then we have NAT test, rubella nucleic acid amplification test, or PCR test. A 4-fold rise in IgG is important to diagnose, and the fetal testing are always there. Korean villa sampling can be done, and amniotic fluid samples with the rubella-specific polymerase chain reaction assay. Prevention rubella vaccine is very, very, very effective protection against the rubella virus, but in pregnancy it is not indicated. It is contraindicated because it's live virus. But remember, once the vaccine has been given inadvertently, this is not an indication for termination of pregnancy.
Sir, you will need to wind up, please.
Yeah. So congenital rubella syndrome, I think we have come to now understand. All the features have been shown here. There is no treatment, but it's the most common VPD of the newborn. So in conclusion, I must say that almost all the perinatal infections present similarity. So differential diagnosis is important. There is a widespread prevalence of toxoplasmosis, I've already mentioned. Most of our clients are already infected, and there is no need to panic. As the disease is self-limiting, and it will not cause any permanent defect, but it will give you the permanent immunity. Only an acute primary infection causes infection. Both IgG and IgM are necessary for the serologic test. Spiramycin is very effective and safe throughout pregnancy and best started before 20 weeks of pregnancy. Ensure that your patient is vaccinated for rubella before entering into the pregnancy. Do not ignore constitutional symptoms so easily, but have a detailed analysis of that. If the infection is diagnosed as first trimester, give her an option of MTP as per the MTP Act. And preventive measures are good hygiene, and of course, ask your client to rear a cat 1 year before planning a pregnancy. That is the tip that I would like to pass on to my pregnant women. Thank you very much for your patient hearing.
Thank you, sir, for giving us such clear messages, and comments from the chairpersons requested. Dr. Pragya, are you there?
I'm sorry, I have taken 2 minutes extra time. Yes, Pragya.
But I think 2 infections, it was really difficult to cover, because he covered it thoroughly, both rubella and
Sir
toxo.
Pragya, I have sent you an unmute request.
Nicely covered, Dr. Ashish, and I think Dr. Manjupuri has also put some comments, a very important one in the chat box. All can see that. Yes, Pragya.
Yeah. Good evening. At the outset, I would like to thank you, Dr. Sheila Mane, Dr. Pratik Tambe, and Dr. Amrita Sarkari Jaipuriyar for giving me this opportunity, remembering me even after I've finished my tenure as governing council member. So thank you so much. And it was indeed a pleasure listening to Dr. Ashish Mukhopadhyay. I mean, it always is. I mean, really, in this very brief, like sort of 20 minutes, you've covered toxoplasmosis very well. And you started with the first case. I mean, although we have so many CMEs, etc., but still this is the problem that, if just with IgG positive, and it usually happens in the periphery, this kind of a thing, that people are just being treated because IgG is positive and being told that, till your IgG becomes negative, you don't have to conceive and things like that. And very nicely, you've dealt with all the scenarios where we have both IgG, IgM positive, and just IgM positive, which means it's a current infection, or just IgG positive, which means she's immune, and about avidity testing also, low avidity and high avidity. But sometimes, low avidity, like you said, it may not really mean that. Sorry, being disturbed by these phone calls.
No worries. Perhaps you should move on. We are already 20 minutes late.
Yeah, sure. Because
so has Dr. Jenna joined? Dr. Jenna? He gave us a message that he is busy in a surgery. So should we move on to the...
No, madam, I joined. Good afternoon, madam.
Oh, good afternoon. So may I request Dr. Kanchan once again to introduce Dr. Jenna? And
am I audible, madam?
Yes, sir.
So,
You are.
Yes.
I can introduce because...
Okay, Dr. Pragya. You carry on. Yes, ma'am.
Well, again, Dr. Saubhagya Jana, very well known to us, and he's a professor and head of OBS and Gynae at AIIMS Bhubaneswar. He's also the Dean of Examinations, and he's a postgraduate from BSS Medical College, Burla, with more than 22 years of clinical teaching and research experience. He has a lot of publications, 95 research articles in different national and international journals, presented 130.
I think Dr. Jenna can start sharing his...
Yeah.
Let's have brief introductions, 3 or 4 lines max.
Can I
Yes, sir. Yes,
Please.
sir. You share your screen, please.
Is it visible, a blank slide?
Yes,
Yeah,
sir.
you need to go full screen.
We can see it.
Okay, so good afternoon, everyone. Namaskar from Bhubaneswar.
Make it
It is
full screen,
heavily.
sir.
Okay, I'll do it. Yeah, is it okay?
Not yet.
Yes. Now it
Now,
is.
yes.
Yeah. So it is heavily raining in Bhubaneswar, thunderstorm now. So I am joining through my mobile hotspot. I don't know, at any time there might be technical issues. Please excuse me for that. So again, blank slide. That means the idea of putting a black slide means I am joining here with the open mind. I am open to criticism, comments, suggestions, and if anybody wants to add anything after my presentations, any points somewhere in my some recent advances are there also, I will come to that also. So I'm moving ahead. Greetings from AIMS Bhubaneswar, All India Institute of Medical Science, Bhubaneswar, Odisha. Then let me acknowledge that thanks to ICOG, all the officers, bearers giving me this opportunity to be present. And another acknowledgement is one of my senior residents, Dr. Madhvi, who helped me in preparing these presentations. And let me declare that I don't have any conflict of interest in this presentation. Then learning objective at the end of the sessions, around 15 minutes. I'll try to cover within 15 minutes. Little bit virology, epidemiology, what is relevant, mode of transmission, different types of these two common infections, common clinical manifestations, laboratory test, and most importantly, how to interpret it, and something about neonatal infections, prevention and management strategies. So coming to the first topic, cytomegalovirus infections. So all of us know that actually it is an invisible burden, that epidemiology and clinical features, if you clinical impact, if you can see, the globally the seroprevalence of IgG positive is around 83%, and in South Asian countries around 57%. But most common part is it is the most common congenital fetal infection and leading cause among the infectious causes of neurodevelopmental delay in infants, and another important cause of sensory neural hearing loss with the congenital CMV infections. And this transmission paradox, you can see two lines are there, red and blue. That means the blue is risk of transmission, preconception, first trimester, second trimester, and third trimester, and the severity of disease. Actually, if you can see, as the pregnancy advances, this risk of transmission increases. However, though the risk of transmission is less during the first trimester of pregnancy, but the disease is more severe actually. Because of one important cause is that because the congenital rubella, that the cytomegal infection, it interferes in the villus differentiation, leading to placental insufficiency and all such of problems. Basic virology, all of us know that this is a double standard DNA virus and transmitted by body fluids. Primary infection is common in childhood, but it can be acquired, that is most in any stage of life. And risk of vertical transmission is 4 times higher in case of primary exposure. And high risk women profiles, actually, you can see multiparous women who usually carry for the children, because from children this infection comes. And child care health workers, people working or in the NICU setup, schools, they are more prone, pregnant women are more prone for this infection. In clinical features, the maternal symptomatic is roughly 7%, not much, but whenever the symptoms are there also, that is non-specific symptoms like fever, myalgia, lymphadenopathy, and all the non-specific symptoms. And fetal infections, if it is congenital infection or fetal infection, the typical blueberry muffins, and mortality is roughly 50%. But the sequelae are more common. It may be neurological or sensory neural deafness that are more common. Then when to suspect and test CMV infection in mother, when there is maternal exposure, I already mentioned regarding these high risk categories, or when there is symptoms suggestive of CMV infection, specifically first trimester or any trimester, let us say in pregnancy, or unexplained liver dysfunction, or most importantly, when we find an abnormal ultrasound findings of the fetus, and these are the features you can see, ultrasound findings. Though this is a busy slide, there are some cranial features, extracranial features, and placental and amniotic features in ultrasound, starting from ventriculomegaly to different splenomegaly, hepatomegaly, edema, polyhydramnios, placental calcification, and all important problems. And in most important is brain neurosonography. In fetal imaging, you can find out that small periventricular cysts, periventricular calcification, intraventricular adhesions. So these are suggestive of congenital, that is fetal CMV infections. There are, of course, MRI signs also, different MRI signs which predict neurological impairment along with other features in MRI. Neonatal signs, clinical, biochemical, and neurological features, well, is mentioned in this PPT slide, starting from intrauterine growth restriction to hepatomegaly, splenomegaly, and other features. Then diagnosing CMV infection in mother and identifying transmission to the fetus. Most important is go for serological tests and interpretation. What is more important, if it is indicated, sometimes you have to go for CMV DNA in amniotic fluid. Then interpretations, you can see two commonly antibodies we do IgG and IgM. Accordingly, we can interpret if the pregnant woman is IgG negative and IgM negative, it is non-immunized. Patient is at risk, then we might have to do 4 to 6 weeks testing. Whereas IgG negative and IgM positive, repeat serology in 3 to 4 weeks. If still only IgM positive, reassurance, likely it might be cross reactivity. That means by 3 to 4 weeks, usually IgG also should develop. If she is IgG positive and IgM negative, that is past infection, all of us know this. However, if she is IgG positive and IgM positive, that is recent infection or false positive, there comes the role of this avidity testing actually. So if the avidity testing, it is low avidity, less than 30%, the infection has occurred recently. If it is more than 60%, infection is old, that is more than 3 months infection. So this same thing, if it is CMV, IgM sensitivity is around 50 to 90%, but non-specific, sometimes cross-reactivity occurs. Combined IgM and IgG avidity testing, it is a sensitivity around 92%. However, confirmation is by amniotic fluid analysis for this virus. And amniocentesis must be done 7 weeks prior, 7 weeks after suspected maternal, and beyond 21 weeks of pregnancy. And these predictive values, if you can see, 95% in amniotic fluid. Then type of infection, if you can see, primary infection, non-primary infection, leading to all sort of complications. And this is the flow chart, though it is a busy chart actually. You can see the most important message from this slide I want to give is, if there are routine testing is not necessary during pregnancy. If they are high risk or they have symptoms, go for testing. Or sometimes if we are doing ultrasound, if there are features suggestive of CMV infection, then go for testing. And secondary prevention will be reduction, that is the by giving this drug, which is very safe, valcyclovir. It is given to reduce the chance of infection, but after 21 weeks of pregnancy. So counseling and all the parts, hand hygiene, that is important. Then coming to the next, herpes simplex virus infection. We know there are two herpes simplex virus 1 and 2, and they came in the neural ganglia. They stay in the neural ganglia, and time to time reinfection produces. And epidemiology, you can see in different part of world what are the epidemiology of this infection. And the infections are primary, and non-primary or recurrent infections. Primary infection is more dangerous and specifically towards the timing of delivery in second and third trimester of pregnancy. And neonatal herpes simplex infection, it is usually three types. It might be skin, eye, mouth. It is roughly 30%. Then it might involve central nervous system around roughly another 33%. Or most severe form is disseminated around 30%. Also, with multi-organ failure, severe form is disseminated neonatal herpes infections. So these are few images starting from ophthalmologic checkup and skin lesions of fetal varicella syndrome starting from microcephaly, cutis aplasia, and chorioretinitis. Transmission of neonatal herpes simplex infection. Most commonly it occurs during the time of delivery. And next most common is around 10 to 25% in postnatal period. Although in vitro transplacental can occur, but it is usually roughly around 5% of neonates have infection due to transplacental transfer. The primary HSV infection, if less than 6 weeks of anticipated birth, has the highest risk of perinatal transmission. And diagnosis, the typical clinical features, but that is not sufficient. We have to go for serologic testing and interpretation of serology testing specific to herpes simplex virus. If you are thinking, of course, herpes simplex type 2 is more important, but type 1 is, as for the recent data, says actually it also can produce the genital infections, and nowadays it is increasing specifically in young persons. Then antepartum care, suppressive antiviral therapy, we can give the drugs, acyclovir, the mentioned dose around 400 milligram 3 times daily, or valcyclovir 500 milligram BD. And most important issues are mode of delivery, and if it is associated with the PPROM, specifically in less than 37 weeks. If primary infection, the chances are high. Recurrent infection, still it can occur, and these drugs has to be given. Then intrapartum care, if it is active lesion is there, that is an indication for cesarean section. And more than 4 hours prolonged rupture of membrane is there also, means there are more chance of infection, then we have to plan for cesarean section. Postnatal care, say practices are required if breastfeeding can be given from the non-affected breast if there are lesions are not there. Then to summarize my presentation, cytomegalovirus management in diagnosis during pregnancy is challenging. Maternal serological tests do not necessarily predict the fetal transmission. Fetal transmission does not always cause neonatal consequences, and prenatal antiviral treatment reduces vertical transmission. That is most important message. Recently it is coming up, and it is very safe during pregnancy also. And regarding universal prenatal screening, it is not recommended, but of late now, after this drug valacyclovir is coming actually, some associations, some societies, specifically Italy and some other places actually, they are recommending to go for universal prenatal screening. Coming to herpes simplex virus, it is a preventable chronic disease. It has diverse clinical manifestations. Though clinical feature is clear-cut, but confirmation should be done by laboratory test only. And most important things to remember in herpes simplex virus is which type of infection, primary or not, and timing actually in relation to trimester of pregnancy, and different types, 3 types, whatever I told of neonatal infection. Of course, antiviral medications, it is given and it has beneficial effect, and mode of delivery specifically, if there are active lesions or prodromal symptoms in genitalia, better to go for cesarean section. So these are my bibliographics, and thank you very much for your kind attention.
Thank you, Dr. Jinnah, for finishing much on time and giving such clear-cut messages. So over to chairpersons for their comments. Dr. Kanchan, Dr. Pragya, over to you.
I think we'll go to the next speaker. They're already quite late.
Okay,
Dr. Parag is also waiting.
All right, sir. So the May I invite the chairpersons for introducing the speaker, Dr. Papadasari? May I go ahead, Dr. Tambe?
Yeah, please go.
Okay. Madam Papadasri is alumnus of JIPMER 1978 batch, and she has 37 years of teaching experience, many publications, 6 book chapters. She has been Dean Research and PG Academics, Shri Venkateshwara Medical College Hospital and Research Center, and many awards and research presentations and publications. So over to you, ma'am, for your presentation. You're welcome.
We can't hear you, ma'am. You need to raise the volume or maybe reconnect your earphones.
Dr. Pratik, time and again from the other end.
Yes, Pragya, ma'am.
No, I said that, continuously being muted from ICOG side.
All right. Okay.
Maybe there's some background noise, ma'am. Ma'am, we can see your presentation, but we can't hear you. There are some audio issues from your side, probably. Can you try disconnecting your earphones and speaking directly? You can switch off the Bluetooth and speak directly. While we're getting the audio issues sorted, I'm very happy to see that there are over 400 live delegates even now on the third day at the fag end of the course. We still can't hear you, ma'am. Support backend team, can you please help her?
मैम ऑडियो पे क्लिक कीजिए आप मैम.
On the bottom left next to audio, there'll be an up arrow.
Select same as system. No, sir. Sir, can I call her, ma'am?
Yeah, please. Do you have a number?
No, sir.
Then can I request Dr. Amrita to do the needful in case she has the number?
Yes, sir, I have.
Yeah, if you can just give her a quick call. In the meantime, let's proceed with the next speaker, maybe, if the next speaker is around.
So the third session would start. This is the last.
That's okay. We'll interchange the speakers because this looks like it might take some time. And we're already quite late.
Vijayanand sir is joined, sir.
Yeah, I'm
He's
there.
joined, so we can have him instead then. Can we have his CV, please, display?
Yes,
Yeah,
sir.
I'm there, sir. Good evening,
Thank you, sir.
Sir, so moving on to the third session, may I call, this is beyond obstetrics, and may I call the chairpersons? May I request
We
the
can have the
chairpersons?
chairpersons later. Just have the speaker.
Okay. Okay. So the speaker is Dr. Jamalpuri, Vijayanand Jamalpuri, and his talk is on neonatal issues in maternal and fetal infections. So over to you, Dr. Vijayanand.
Okay, ma'am. Am I allowed to? I'm trying to share, ma'am. Wait a minute.
Yeah, please go ahead.
Yeah. So, Bear with me. Good evening, everyone. So just bear with me. Yeah. Can you all see my slides?
Yes, sir, please go ahead.
Yeah, okay. So first of all, I want to thank the organizing committee, ICOG, and also FOGSI for giving me this opportunity. And it's really 400 delegates. Probably this is one of the highest attended webinar I am presenting it. I was asked to discuss about neonatal issues in maternal and fetal infection. So I just want to give first an overview of what happens in maternal infection. And I think you had an excellent session on intrauterine infection. I wish I could have attended all of them. I could not, but I've attended the last one. So you have placental transmission and causing embryopathy. You have ascending infection. You have intrapartum infection causing with the other risk factors. I don't need to tell you, obstetric team, that various risk factors for the mother causing the maternal infection. And it has got huge impact on the fetus as well as on the baby once born. And the impact ranges from a fetal loss, stillbirth, and severe neonatal presentation with significant morbidity, even mortality. And the morbidity which not only limits in the neonatal period but continues throughout the life. So you can see how it can affect, and it can cause fetal growth restriction and congenital anomalies and so on. And of course, if the fetus was not affected or impacted in the life, but immediately after the birth can be impacted, and which may continue for life. So all these infections not only have the impact on the mother and the placenta on the fetus, but in turn, these impact on the mother can further impact the fetus. So it's like a vicious cycle. So I don't need to read that slide, you can see, and leading to the more and more morbidity. So first, I don't need to, I talk about briefly about TORCH. You had a detailed discussion, and I've just listened to the on a CMV and herpes excellent discussion. And I'm sure you all are concerned about the torch infection. I give a overall brief view of how much morbidity it causes, but again, to tell the data is variable. We don't have Indian data exactly what is the incident, but again, you know better than me. And so is one data says 2 to 3% of all congenital anomalies are due to intrauterine infections. But again, there are so many variables to tell the current incidence and prevalence. And what does it cause? So, okay, these are some of the pictures you can see. That is a blueberry muffin rash, and there's a various uh, systems which can be involved and affected. Your eyes with chorioretinitis, cataract, microcephaly, as previous speaker showed you the cerebral calcification, anomalies, and ventriculomegaly, heart defects with VSDs, PDAs, and it can cause hepatitis, and it can impact every organ based on which infection you are referring to. And this is one, and also in the previous talk, you've seen some of the images of congenital herpes infection. And we had, when I was working in Auckland, in New Zealand, we had a 28-weeker who was severely affected with the congenital herpes, where it is like 80% burn. Actually, skin is all filled up. Unfortunately, that baby could not make. And more morbidity you can see. That is a cataract due to rubella, and these are the calcification in the brain. It's not the calcification it harm, it's the impact of the parenchymal change, which ultimately make these babies to become neurodevelopmentally disabled. And the chorioretinitis causing the severe visual morbidity. And so the brief summary of all these infections, I'm not intentionally touching upon HIV, TB, all those are topics on their own, but you know that these things cause significant morbidity and even mortality. And so I'm not reading the slide. You can see the salient features of each infection and how they can be. But some of these infections can be treated and limit the spread to the fetus as well as the newborn. One classical example is syphilis. So congenital syphilis can be preventable if you treat effectively mother, and then some of them can be prevented with the vaccination. Unfortunately, rubella vaccination is not universal in India yet, but that may happen eventually. And then with some of the torch infection like CMV, congenital CMV, it can decrease the morbidity to some extent, but the sequelae continue. But the close follow-up, early interventions can limit the long-term disability and improve the outcome for them. And of course, HSV, I've got an interesting case to show you. I've got a couple of case examples. And HSV is also proactively identifying those mothers with a perinatal infection. Of course, we can't do much about congenital. Again, you can treat if you effectively, but not every baby can be infected based on is a primary or secondary. But if you have perinatal, I'll show you the example, and can be very fatal, very fatal. So there's a nice review guideline in the Indian Academy of Pediatrics. If anybody interested can go through. And then comes the most worrying thing as a neonatologist for me is the sepsis. Sepsis is the one of the killers across the globe among the babies, and 2/3 of that is the early onset sepsis. Is the maternal fetal inflammation infection is responsible? Yes. And so it says this WHO data shows that 550,000 babies die every year with the infection. I think, and India is one of the major contributor. I think probably highest number of deaths, neonatal deaths due to infection across the globe. And there's our own study from Delhi, and somebody who is from Delhi might know famous Dennis trial. It showed that around 15% of the incidence of sepsis, again, data is variable, patchy, and this data showed that if you have a sepsis culture positive, the likelihood of baby dying is 50%. There's a culture negative sepsis, 25%, which is huge. And also we see not only death, we see the long-term morbidity, and like if the baby had a acute kidney injury as a part of sepsis, that can lead to a sequelae, and also meningitis can lead to a sequelae. And these inflammatory responses can also cause, if they are preterm, intraventricular hemorrhages and periventricular leukomalacia, which are the two major causes for neuro disability in the later life. So it's a serious thing. So, and it's a huge impact on the babies with the infection. So, okay. And if you look at what are the risk factors we are worried about, which can cause with the look at this meta-analysis. So if you have a clear chorioamnionitis, the risk of goes up to 4 to 6 times. And a maternal fever, intrapartum fever, and again, there's a definite criteria of chorioamnionitis. This is where our obstacle is talking to us and having the dialogue of how sick the mother is, and what are there any microbiological parameters or inflammatory parameters, how much you worried about the mother, would also allow us to decide how much we screen that baby and treat accordingly. So, and again, maternal intrapartum fever, maternal UTI, and we know that one of the common reason fetum birth is insidious infection, and maternal diabetes does increase. GBS colonization, I don't think it is relevant for India, and it is not dominant. It is mainly in the Western countries. So that's why we don't routinely screen. You know better than me. So, and what are the pathogens? The moment you say early onset sepsis, GBS is mentioned in the literature, but that comes from the Western literature. But what does the Indian bugs are? Gram negative. Gram negative bugs are killers. E. coli, Klebsiella, Staph aureus, Acinetobacter. Unfortunately, these are becoming multi-drug resistant. We see any given time on our neonatal unit, babies of early onset, both the late onset, do have gram-negative sepsis, and so that some of them carried from the maternal without even mother knowing that she has infection. And again, having that dialogue of with your neonatal colleagues or pediatric colleagues, what likely infection mother have, can help us to decide how best we can help these babies to decrease the morbidity and even mortality. Okay, antibiotics, what you give? Well, when I was a PG, even in UK, New Zealand, the first line we used to give ampicillin and gentamicin, but unfortunately, our own data says ampicillin doesn't work anymore. And again, there's a difficulties. We are in a situation where we don't even have a proper local antibiograms and across the units in India. And gram negative cover is important, and amikacin, piptas, meropenem based on how sick the baby is and what are the clues from the perinatal history and the maternal microbiological investigations. And you need to have your own local antibiogram to decide what. For example, in my unit, we use single agent, that is amikacin, for term babies with early onset sepsis, and which works well because that is sensitive. And we stopped using ampicillin anymore. Okay. And I know it's just talking theory can be boring. So I've got some few interesting cases, which are the real cases. And oh, I'm running out of time. I did not realize. Okay, so I'll skip through. This is a primary mother, 27-weeker, P-priam from 26 weeks onwards. There's a history suggestive of maternal chorioamnitis. They are concerned and they delivered, and HVS grew E. coli. This baby was born in a very poor condition and in intubation, ventilation, multiple inotropes, leukopenia, thrombocytopenia, blood culture grew E. coli. And unfortunately, this baby did have IVH, but that resolved and did improve and go on. So the fetal inflammation because of the infection is the reason and the concern what happens in these babies. So it can cause brain injury, it can cause lung injury, it can cause multi-organ. This baby, for example, has shock and has had the IVH, but thankfully this baby got better, eventually went home. Have another few interesting cases. I'll try to see whether I can do. And there's a baby H, LSCS, fever and dull activity on day 3 and abnormal movement day 5. And mother had a fever day before. Otherwise, everything was fine. And history of fever in mother 1 day prior. Yeah, the key entry. And this baby has lethargic and hypotonia, and other system examination was normal. And then there was a thrombocytopenia, you can see. Usually in this situation, we think of dengue, but dengue serology was negative. And other investigations suggestive of meningitis and metabolic disorders are negative. And this baby had MRI showed some diffuse diffusion restriction in certain areas. I don't want to read in detail. And has got this pigmentation, this classical of chikungunya. And this baby had chikungunya IEM positive. There are several case reports which are perinatal transmission chikungunya. And the prognosis is variable, but this baby did well. And the third case I try to cover, term HEA baby, 36-year-old primary mother, non-consanguineous marriage, delivered by LSCS, and cried habitually, discharged on day 5. Day 15, had fever, admitted to referral hospital. CU has some pus cells, treated as the urinary infection. CSA was not suggestive of, but this baby encephalopathy, respiratory distress, and started bleeding from the oral cavity, and the liver was huge. And this baby in no time at DIC became very sick, and anemia, thrombocytopenia, and leukopenia, and severe transaminitis. This is a fatal, I'll show you. And next 24 hours became very sick and multi-organ dysfailure, everything done. So 2 minutes, okay? So I'll take 2 minutes, yeah. And these are the differential we thought about. But when we went back and asked the history, and the mother fever during the postpartum period, mother had a blisters on the thumb, as you can see, and the lower abdomen suspected to herpes. And this is HSV PCR, and the baby was positive. This was a severe fatal HSV. If you recognize in time and treat, this is treatable. And so it's important to have that history. And the last, so this baby eventually succumbed, did not make it. And so last one, I'll quickly go through little bit of bad. So this mother had got some bad obstetric history and fever prior to delivery, and post delivery she had multi-organ dysfunction, became very sick, and the baby was 35 weeks, doing fine until day 10, and then suddenly baby became very sick, went into circulatory shock, intubated, ventilated, several inotropes, and very sick, and thrombocytopenia. This baby had dengue. So dengue, initially babies can be fine, but eventually can develop. We had a series of cases, actually it's more than 12 now, and can make them very sick. And the take-home messages are maternal fetal infection results in significant morbidity and mortality, and 2 to 3% congenital anomalies, or I would say significant proportion of congenital could be intrauterine infection, and risk assessment and timely management into antibiotics. The neonates at risk of early onset sepsis is important to decrease the morbidity and mortality, and gram negative is the killer in India for neonatal sepsis, not gram positive and not GBS. Risk-based neonatal evaluation is commonly used for screening, and empirical antibodies should be guided by NICU or local antibiograms. I stop it there. Thank you for the organizing committee to give me this opportunity.
Thank you, sir. Fantastic talk.
Yes,
I think we have the previous speaker who's waiting. She had some audiovisual issues. We request Madam to share her screen and go ahead. She's managed to iron out the audiovisual problems.
Meanwhile, can we
Ravina?
request our chairperson to give a comment on this talk, sir? Meanwhile.
Dr. Sashikala here. Sorry, we will not have any such introductions. We'll do away with it. But Dr. Vijayanand is our neonatologist. I work in the same hospital. They work up a lot on all the neonates. But from obstetrician's point of view, I think that simple things of proper asepsis and restricted pelvic examinations and screening for UTIs are very important. And these days we have more and more mothers with diabetes, GDM in pregnancy, which again adds to the risk, and also PPROM cohorts also cause problems. So, and also when we do an ARM, I think delaying the ARM and properly, timing it and maybe avoiding it if possible also will help. And these gram-negative organisms in our hospital, we don't give we only give antibiotics for patients with PPROM. Normal low risk mothers, we try to avoid giving antibiotics. One prophylactic antibiotic prior to elective cesarean section also, to prevent this multi-organ, resistance, multi-drug resistance. And also having an awareness of this fetal FRIS and the cytokine storm. If we see 1 or 2 cases, I think all obstetricians will be very careful with how we manage our patients in labor. Thank you very much. That was a lovely presentation, Dr. Vijayanand.
Thank you, ma'am. Thank you, ma'am.
Thank you, Dr. Vijayanand. I would like to say that a clear-cut message is from this webinar that all the obstetricians should take care of the risk factors in the intranatal period and just after delivery, also in the postpartum phase. If any infection is there in the mother, they should talk to the pediatrician so that a very close watch could be kept on the baby, a 6-hourly watch or whatever investigations the pediatricians want to go for, so that any infection is caught in early in time and treated in time. That is the message for all of us. Thank you.
Thank you, ma'am.
If the audiovisual issues are sorted, can we have Madam's presentation, please? We can't see your screen, ma'am.
We can see her name on the top.
We can see the browser window. We can see the file explorer, but we can't see the presentation.
Oh, it has come.
And I think we still can't hear.
Yeah, Dr. Vijayanand, most of the times what happens, we are not aware that the baby is suffering because the patient doesn't come back to us.
Yes, ma'am.
And that is how we lose the track and we don't know the seriousness of this. Even the congenital rubella syndrome, they
Yes, ma'am.
may not come back to us, but So that's what
So-
it happens.
Also seasonal also. Whenever
Yes,
there is dengue and chikungunya season, we have to always keep that in mind. If a mother has fever, don't just think it is a mild viral fever and not investigate. We have to investigate so that we can save the babies. The babies can be
He has
taken
been
care of.
muted, I believe, by the host.
Yeah. Yes, ma'am.
Backend
Always
team,
not
please
muted.
unmute Dr. Papa
Please
Dasari.
unmute.
Yes, Dr. Vijayanand.
Yeah, it's always important to have that conversation going on, ma'am. So because lot of maternal issues can result neonatal morbidity. So having the discussion, for example, the typical example is dengue, ma'am, perinatal dengue. They will be fine in the initial 5 days, the babies. Then the babies collapse. So if I would have discharged that baby and that baby would have actually succumbed, the example case which I've shown. And also we have a very good communication between us and our obstetric team, as ma'am Shashikala said, that we will keep talking about what are the HVS done, what are the other investigations done, because that will allow us to guide the therapy in the baby. So if it is a carbapenem resistant bug in the mother HVS, I wouldn't be starting simple amikacin. I would be starting meropenem or something whichever is sensitive. So yeah, so that will be really helpful. As you rightly said, it is important that we talk to each other
Take
all the time.
backend team, just see whether she is unmuted.
They've already tried for 15 minutes, ma'am. I think it's not working. We'll proceed with the next speaker, Dr. Parag Biniwale, sir.
Yeah.
So before moving to the second talk by Parag Biniwale sir, may I introduce the chairpersons for this session. Dr. Reena Srivastava ma'am, she is the ex-HOD BRD Medical College Gorakhpur and past president of UPC.
I think Dr. Papa Dasari can,
It's all okay.
she can mail her presentation to the backend team and then she can speak from her phone. I think that is the another alternative. Doctor, please try that way. Talk to the backend team. Shreya, Dr. Amrita, just
Yes,
talk to
ma'am.
her. Yeah.
Yes, ma'am. Okay, I'll do that. Okay. So many publications to her credit and attended various
Amrita.
conferences.
There's
And
less
our
time.
second, yes, ma'am. And our second chairperson is Dr. Sneha and Managing Director, Sukanta Hospital, Yavatmal. She has also organized various conferences and she has been the chairperson of Breast Committee, FOGSI.
Thank you.
And Dr. Sasikala Kola, we have heard. She is the consultant OBGY Birthright by Rainbow Hospital and trained in robotic surgery long back in 2017 and contributed chapters in many books of OBGY. So over to the chairpersons, and may I request Madam Reena to introduce Dr. Parag. Over to you, chairpersons.
Yes. It's. I'm happy to introduce Dr. Parag Biniwale, although everybody knows about him. He's senior consultant to OBGYN Pune, PG teacher in Unit Head, Kamala Nehru Hospital, chairman Indian College of OBGYN, president Menopause Society Pune in 22, president Pune
Reena, madam, thank
OBGYN
you. Thank you.
Society.
Don't waste
So
time
you
in
hold
that.
so many accolades to your credit. Please come with your topic.
Sure. Thank you. Good evening. It's indeed a pleasure to be back in the ICOG certificate course. At the outset, let me thank Chairperson Dr. Sheila Mane, Vice Chair Dr. Sadhana Gupta, who's the convener of this program, and of course, the Dynamic Secretary Dr. Pratik. Thank you, Amrita, for reminding me that I'm supposed to be speaking today. I'll try to finish as early as I can. I'll be talking about vaccination during pregnancy. So if I have to speak for just for 1 minute, I can show one slide and finish it, but I'll just quickly go through this presentation. This is going to be the flow of presentation. Vaccination is something which is simple, safe, effective way of protecting our body from harmful diseases. All of us are very well aware of this, and it is in a way of to build natural defenses against various infections and makes our immune system stronger. Of course, there are so many types of vaccine, toxoid, live virus vaccine. Not all of them are used in pregnancy, especially the live virus vaccine, which are actually contraindicated. So any of these conditions shown on the screen, the vaccination in pregnancy is a strict no-no. There are so many vaccine preventable diseases, and that is something which is really important as far as human health is concerned, or I should say women's health in particular is concerned. What is the need of having vaccination, especially in pregnancy? Though we may not see these cases in person, this is what the WHO says. There are over 1,000 cases of tetanus, as in the babies was noted, neonatal tetanus. There were cases of over 1,700 neonatal diphtheria and over 500 cases of neonatal pertussis. Mind well, these are the situations which can be really troublesome as far as the baby is concerned, and there are quite a few babies who succumb to these conditions. So it is worthwhile considering doing something to prevent this, and the best way to do it by vaccinating our women. Of course, when we talk about vaccination, the average coverage is definitely not 100%. Even in the countries like US, the vaccination, there is a certain gap as far as the vaccination is concerned. Of course, in our country, though there are millions of pregnant women who are targeted for immunization annually, not all of them receive these vaccinations. The only vaccine probably these women receive is the TD, that is tetanus and adult diphtheria, which is now replaced, which has completely replaced the tetanus toxoid. When we talk about vaccines in pregnancy, we are always concerned, will the vaccine increase the risk of transmission of disease in the fetus? And the answer is no. Should pregnancy be terminated in women who receive vaccine accidentally? The answer is no. Of course, extensive counseling is required before taking any such decision. Coming to the rationale of vaccination is pregnancy. We know that pregnant women and their feti are amongst the most vulnerable population, and they can be severely affected by certain communicable diseases. So it is worthwhile vaccinating all our pregnant women in order to prevent fulminant diseases, not only for the mother, but also for the fetus in utero. And to protect the mother, it is important that we offer them vaccination like influenza, tetanus, etc. And we protect them from infections that are potentially severe for herself and for the unborn fetus. And indirectly, we are trying to pass on the passive immunity to the baby via mother. And mind well, breastfeeding is also an important aspect because breast milk to protect the baby in the first month of life has an extremely important role to play. Vaccination of pregnant individuals aims to increase infant antibody levels, and here, ideally, maternal vaccination should also increase and maintain the antibody concentration in the newborn to a level needed to prevent immunity until primary series of infant immunization begins. The maternal antibodies are transferred across the placenta to the fetus, and it is generally observed that there is a progressive transfer of maternal antibodies to the fetus by around 17 weeks. And by the 35th of weeks of pregnancy, the fetal IgG concentrations of most IgGs exceed the maternal concentration that we then know these babies are ready to be born in a protected state. The amount of maternal antibodies will also depend on the maternal antibodies. So the maternal titers and other antibody-specific factors are important. The placental health is equally important because the placenta is the one which will transfer the IgG to the fetus. And of course, the gestational age, IgG transfer will increase as the pregnancy progresses. So vaccination in pregnancy results in active transport of maternal antibodies across the placenta to protect the fetus. And the breastfeeding also has very important role to play in transfer of maternal antibodies, especially in secretory IgG antibodies are released into the colostrum and breast milk. And once the baby ingests it during breastfeeding, it will definitely provide mucosal immunity to the fetus. So coming to the vaccination during pregnancy, and these are the vaccines which are recommended by FOGSI ICOG, the tetanus, diphtheria, pertussis, and of course the influenza. All of us have used tetanus toxoid for umpteen number of years. We always used to give 2 doses 28 days apart, but this can be given anytime after second trimester. In fact, in public sector, it is also given in the first trimester. But please note now the TT is replaced by TD, that is tetanus and adult diphtheria. And Tdap is the vaccine which has shown important role, and we have almost replaced the second dose of tetanus toxoid or TD by Tdap. We know that regular pertussis vaccine is contraindicated during pregnancy, but this vaccine, the Tdap vaccine, can be given between 27 and 36 weeks of gestation. It is preferably given in the earlier part as to maximize the maternal antibody response and passive antibodies transfer to the infant. These are some of the important tips for all of us. More than 90% of infants under 2 months of age with pertussis require hospitalization, and that's a big rationale for vaccinating our pregnant women. So FOGSI ICOG recommends 2 doses of TT at least 28 hours, 28 days apart, commencing from the second trimester, and now we have replaced the second dose of TD or by the Tdap vaccine. Coming to the influenza vaccine, the influenza vaccination against influenza A and B is recommended from 26 weeks onward, but now the current recommendations are that it can be offered at any point of time during pregnancy. And in case of a pandemic vaccination, this can be given anytime during the course of pregnancy. There is a higher incidence of complications noted if the pregnancy is infected with H1N1 or H3N2. So it is worthwhile considering this vaccine to be administered to all our pregnant women. I understand that it is expensive and little difficult to administer to each and every woman in the public sector, but at least in the private sector, we can consider giving this vaccine. And the safety of this vaccine is very well documented. There is no increase in risk of untoward maternal or fetal outcome, and there is excellent and robust safety profile of multiple inactivated influenza vaccines, and this has been noted over decades. So FOGSI ICOG in 2018 has recommended influenza vaccine for all pregnant women, and that can be administered at any point of time during pregnancy. Coming to the vaccines in specific situations, and rabies, all of us know that has near 100% fatality if any human being is infected with rabies. So the vaccine has killed virus. The safety of this virus is unknown. But if there is an exposure, it is important that we consider this vaccine. There is no role for prophylaxis. But if there is a history of dog bite, we must consider such a case individually. The pneumococcal vaccine, there is no increase in risk of disease or severity of disease. But again, it is indicated in women with asplenia, metabolic or renal, cardiac, pulmonary diseases, and especially in immunosuppressed women, not recommended for each and everyone. Meningococcus is indicated in unusual breakout situations, which is absolutely rare. And the typhoid vaccine, again, we are aware that this is a condition which may result into significant morbidity and even mortality. Oral vaccine is preferred, and this again is not recommended routinely. There are specific immunoglobulins which are really important, especially the hepatitis B, which is indicated in post-exposure prophylaxis. And of course, exposed newborns need immediate post-exposure prophylaxis as soon as they are born. The rabies immunoglobulin, again, is important, and this is used in conjunction with the killed vaccine virus. And specific immunoglobulins like tetanus may be used with tetanus toxoid as a post-exposure prophylaxis. It is usually administered as an intramuscular single dose, but again, this is something which is needed in very specific and special situations. So is true for varicella, against a vaccine which we would not recommend to each and every woman. It is not indicated for prevention of congenital varicella, and it can be given in specific situations. Coming to the vaccination in emergency situations, and all of us have done it, the COVID-19 vaccination, we were really not sure about the efficacy of the vaccine, but we did believe that the outcome of our pregnant women would be a big challenge because there were quite a few mortalities. A lot of women did require ventilatory support because of pneumonia. There were quite a few ICU admissions, and of course, even the newborns suffered by prematurity miscarriage or even stillbirth. And that is how we decided, all of us decided to vaccinate these women in order to achieve a herd immunity, because we didn't want the women to have an increased risk of prematurity, severe disease, and even stillbirth. And these were the flyers which were circulated by the government of India to reiterate the importance of vaccination during pregnancy, and all of us did comply to it because we wanted our women to be safe in this pandemic condition. Of course, the vaccines have certain side effects which we must keep in mind. There could be fever, which is generally low grade. There could be soreness and redness of the injection site. Rarely women do experience headache, fatigue, and severe allergic reactions are absolute rarity. Just a word about respiratory syncytial virus vaccine, and this is something which the WHO recommends after 28 weeks of pregnancy. This particular vaccine is currently not administered to our pregnant women, but in the Western countries, this vaccine is offered to some women, typically between 32 to 36 weeks of pregnancy. And just to conclude, this is a slide which all of us must remember, that these are the 3 vaccines which are extremely important in pregnancy, and we have to administer them to each and every pregnant woman. So ladies and gentlemen, each mother is precious, so each is each baby, and let's protect them by giving them proper vaccination at the right time, so that we do whatever is best possible for all of them. Thank you. Thank you very much.
Thank you, sir, for being so much in time. And may I request the chairpersons for their comments?
Yeah, so excellent talk, Parag. As always, a very good evening to all of you. This is Dr. Sneha Buyar, and thank you, Madam Sheila Mane, Dr. Pratik, Dr. Ashok Kumar sir, and Dr. Sadhna Gupta, and the entire team. In fact, hearty congratulations to all of you. Just few comments from my side. As Dr. Parag has extensively and precisely covered the topic very well, vaccination during pregnancy is in fact a very important, powerful, and evidence-based intervention that we can do antenatally to safeguard the health of the mother as well as the baby. And as all of us know, that pregnancy is a condition where the mother is most vulnerable to so many diseases. So in fact, the vaccine not only reduces the severity of the disease, but also confers the passive immunity to the fetus and the newborn baby at a period where it is most vulnerable and it is not, vaccinated. So it is very, very important to vaccinate the pregnant woman. And I would strongly reaffirm that it is our collective responsibility to make sure to vaccinate the pregnant woman as per the recommendations. So thank you so much once again for having me on board. Thank you so much. Over to you, Dr. Amrita.
Thank you. Now we come to the end of the 3rd session. Thank you, speakers and the chairpersons.
Speaker, is she able to manage to speak?
Probably.
Thank you, Dr. Parag, our ex-chairperson, for coming there on our program. Thank you. Thanks a lot.
My pleasure. Thank you, Sheila.
Thank you, Parag, for your blessings and guidance always.
Dr. Desari?
Can she hear actually?
Yes,
She can hear us, but we cannot hear her.
मैम सर मैंने उनको बोला भी आप मोबाइल से ज्वाइन कीजिए, मैं आपका पीपीटी शो कर देती हूँ, पर तो भी आवाज नहीं आ रहा है उनका।
ठीक है, उनका पीपीटी भेजने को बोलिए, उनका पीपीटी हम अपलोड करेंगे।
मैम मेरे पास है पीपीटी, पर मैम उनका भी आवाज ही नहीं आ रहा है ना मैम।
बाद में सब प्रोग्राम के साथ उनका अपलोड कर देंगे।
That's fine.
Okay, yeah.
I think we can go ahead with the panel then.
Yes, let's move on to
the post-test and the valedictory, so it's a very long extended program.
Yes, sir. So let's move on to the panel discussion, clarity in difficult situations of suspected fetal infections. So our moderator for today is Dr. Vandana Bansal. She is additional professor OBGY and HOD, Ultrasound Department, Nauroji Wadia Hospital and Maternity Hospital. She is a super specialist and medicine interventionist also. And she has so many awards for best paper and best publications. So, moderator for today, and the experts are Dr. Geeta Kolar and Dr. Anita Cole. Dr. Geeta Kolar is the Director, Department of Fetal Medicine, Fernandez Hospital, Hyderabad. Dr. Anita Cole is from Indraprasth Apollo, and she is the clinical coordinator and also head of the Apollo Center of Fetal Medicine. The panelists are Dr. Neha Gupta, Senior Consultant, Fetal Medicine and Genetic Department, Kailash Hospital, Noida. Dr. Sandhya Rani Panigrahi, she is an OBGY consultant. Dr. Elizabeth is a Senior Consultant and HOD from Kochi. Dr. Sangeeta Yadav is Professor, Department of Maternal and Reproductive Health, SGPGI, Lucknow. And Dr. Mona Agrawal is a consultant OBGY, Senior Consultant and Director, Surabhi IVF Center, Moradabad. So over to you, Bansal ma'am, for your moderation of the panel.
Thank you so much, madam, for this opportunity. And the whole day we've been listening to fetal infection. So now let us go through the cases as to how we apply all that to our clinical practice. So I will want to share my screen. Yes. Hope I am audible.
Audible, visible, please go ahead.
Yes, ma'am. So we know our experts are there, Dr. Geeta and Dr. Anita Kaul, and our esteemed panelists. So we start off with just a basic introduction, then go on to cases. So we know there is clinically silent infection, but they are associated with a lot of maternal to child transmission. The problem with fetal infection is that the serology is often confusing. So we will go through the first case as on the serology as to how we can use it for a clinical practice. And we also know that the ultrasound is the key for diagnosis for infection. So with this background, I will want my panelists to be with me, and I will ask Dr. Mona to start with. She's an obstetrician, so there is where the patient will first reach you. So do you, as a routine, do antenatal screening for torch infections, Dr. Mona?
No, we normally don't do routine screening for torch infections in antenatal period, and there are some indications in which we have to do torch antibodies, and it can be done in a patient who has been exposed to the infectious pathogen. And if there is sonographic markers of fetal infection or with or without FGR, and we can do if there is sudden intrauterine death of the baby, and if there is very early intrauterine growth reduction with no placental disease, then also we can consider fetal infections. And in case in human immunodeficiency virus HIV, we will think about doing torch antibodies.
So it is very important to say that it is not to be done as a routine. It is only when it is really indicated and the points are given here. So Dr. Neha, you are a fetal medicine specialist. So
Yes.
what are the ultrasound markers of fetal infection when you do an ultrasound you will get worried about for all of them? Toxo, rubella, CMV, parvo, Zika.
So these markers are usually non-specific, and similar markers can be seen in all sorts of fetal infections. They can be placental and fetal. You can have placentomegaly, placental calcifications, oligohydramnios. Then there can be fetal markers which can be cranial and extracranial. Now, cranial are the most common markers, with ventriculomegaly being the most common, followed by calcifications. Then there can be cerebellar abnormalities in the form of hypoplasia, cysts, or cerebellar hemorrhage, intraventricular synechia. We can have microcephaly. We can have presentation in the form of cortical malformations like oligogyria or pachygyria or polymicrogyria. Then you can have it involving the other organ systems, like there can be a small for gestational age baby, hyperecogenic bowel, abdominal or liver calcifications, presence of fetal ascites, or hydrops,
or in fact, even fetal anemia in the form of high MCA-PSV in specific infections.
So Neha, you mean that even if we've done an anomaly scan and it is normal, at every scan you will have to look for markers for infection to be able to pick them up?
Yes, ma'am. But we have to understand that only 50%, in 50% of the cases, we will identify significant markers on the ultrasound.
Yes.
So usually whenever we do a scan, we see all these markers, and these markers are usually apparent when we are doing an anomaly scan, or for that matter, any scan.
So Neha, we are now with this antibody titers that we look at. So there's a lot of confusion. Can you solve the confusion for all of us?
So we mainly consider with two antibodies, that is IgM and IgG. So IgM is considered with an acute infection. It appears initially, and as then it rises rapidly, and after a period of maybe 1 month or so, then it falls down, or it may remain elevated at very lower levels for years. After IgM, then IgG starts appearing, and IgG then it takes time, reaches a peak level, and then it plateaus and maintains at a stable level for a prolonged period. Now, IgG is a marker of that the infection has happened in the past, high levels of IgG. Then we also consider IgG avidity. IgG avidity, higher the avidity, that means more stronger is the binding of the IgG. So that indicates that older the infection it is. So high avidity indicates that the infection was more than 3 months.
Yes, so that means our avidity is helping us when there is an IgG and IgM positive both. So
Yes.
a high avidity would mean that there is a old infection, and a low avidity would mean there is a recent infection, a 3 months lag that we see. So this is a guide which I've made for myself, and also maybe everybody can see. If both are negative, there's no infection, but the patient is susceptible. If it is IgM which is positive, then there is possibility of infection more if the IgG is negative. If both of them are positive, then avidity is going to help me out. So now with this background, let's go on to our first case of toxoplasmosis. And for that, Dr. Sangeeta, you're a maternal fetal medicine specialist. You can answer these questions for me. How does it present toxoplasmosis in the mother and in the fetus?
Basically, toxoplasmosis is a protozoal infection, and most of the time it is asymptomatic in the woman. And whenever the symptoms are there, it may present as non-specific symptoms like fever, malaise, lymphadenopathy. So these kind of symptoms may be there. So, and usually it passes off without any sequelae. But if the infection passes on to the fetus, it can present with many manifestations, as has been told already by Dr. Neha. Like it can present with the cranial, extracranial manifestations, as well as the placental manifestations. So I'm not going to repeat everything, but then the ultrasound manifestations can be there. And then, of course, the serology will help us to identify whether the infection, whether the mother is infected or not.
So, Dr. Sangeeta, I have this patient. She's had one ectopic, then one IUFD at 15 weeks. So she had an NT scan, which was normal, but the screen came out as high risk for trisomy 21, majorly because of very low PAPE. And then suddenly, after the FISH was done in the products, there was a sudden IUFD, and the products showed a normal FISH. So now that there's an IUFD just happened, will you do a torch test for her? Sangeeta.
Well, yes, the torch, we can see that there is low PAPE. So low PAPE is a marker for whenever there is a low PAPE, it can lead to stillbirths. So that we know, intrauterine death, it can happen. Also, a torch test can lead to intrauterine death. But then usually it will not cause recurrent IUDs or recurrent abortions. So, yes, we can go ahead with the torch test to ascertain whether this is the cause of IUD in this particular case.
So we want to find out whether it is placentation related or it is infection related. So yes, a test was done and it came out as IgM positive and IgG also positive. Now the gynecologist started her on spiramycin in the non-pregnant state. Then again, next month she got done again positive IgM. December again, IgM, IgG both positive. Then waited for a few months, different lab, again IgG, IgM positive. So, Dr. Sangeeta, do we give treatment in a non-pregnant state?
No, we do not give treatment in the non-pregnant women. We only give treatment in the pregnant women to prevent the transmission of the infection to the fetus. So spiramycin is to be started only in the pregnant women. And one thing which is very, very important with the toxoplasma infection is that the very few labs are standardized for the toxo IgGM and IgG test. So whenever the results are inconclusive, ideally the sample should be sent to the standardized lab.
So here, this patient was, IUI was done and she came positive. And with these reports of toxo IgM, IgG positive, she has reached us. So yes, you've said that no treatment required. How long should we have waited? And now that she's pregnant, what will we do?
Now, first of all, we need to know whether since the reports are very, very inconclusive, I would like to do the avidity. And if the avidity is high, then it suggests an old infection and nothing needs to be done. But if it is a low avidity, then we need to start her on spiramycin. And then after starting spiramycin, we need to follow her. If we find any ultrasound manifestation of infection, or if we find, okay.
So here the avidity, as you said rightly, because this is the first trimester itself, and the avidity was high. So have I proven that the mother has no infection?
Yes, she's having no active infection, and this is suggestive of an old infection.
And she has been having it for a year now. So it is an old infection. So other tests were done, protein S, antithrombin, and she was started on low molecular weight heparin and aspirin. Do you want to continue spiramycin for her? Do you need to do an amniocentesis?
No, we do not need to do amniocentesis also, and we do not need to continue spiramycin also.
So the learning here is that avidity helped us in the first trimester to decide that the mother has no infection at all and she doesn't need to be tested for amniocentesis, and no spiramycin is required. So learning from here is that IgM may remain positive for a long time, and the avidity is going to help us in deciding what the infection is. So now with that background of how we look at serum markers, I come to the next of our panelists. Here I want Elizabeth and Dr. Neha to be with me for these cases. So Dr. Elizabeth, this is a G2P1 previous LSCS, female child, ICT negative, blood group positive, NT anomaly was all normal. And then at this 27 weeks, we have ventriculomegaly, there is some calcifications which I see, there's some periventricular masses also, there's a thick placenta, and there is also pericardial effusion and hydrops. So when you see this and the patient says, oh, why did I get this? How are you going to explain to her? What will you do?
This patient definitely has a picture of non-immune fetal hydropic features. So all the features are suggestive, and we need to counsel her that she has to be worked up in detail regarding the intrauterine infection. So the first thing would be to screen her for the maternal intrauterine infections. And of course, definitely we need to be sure, since we have done an NT and an anomaly and the initial chromosomal workup, we have also ruled out that part of it. So a detailed fetal medicine scan to definitely assess and confirm the findings that have been mentioned in the fetal medicine, and fetal MRI in the present setting also would be ideal. So we would counsel her regarding the high chances that she might be having an intrauterine infection. The torch panel would be done, and from that we would try to find out what could be the cause of the same.
So, Dr. Neha, the ball is in your court. There is an infection, probably, but it is a non-immune hydrop. So, Dr. Elizabeth said that we will do a maternal torch at 28 weeks. Is it going to help us, or do you want to do an amniocentesis? The growth is also on the lower side. The Dopplers look normal. So, it's a non-immune hydrops, FGR, and we are suspecting a torch infection. Dr. Neha.
I will not do a maternal serology at this stage because we know that even if we do an avidity, it will indicate an infection for more than 3 months, and we want now a conclusive answer. So, non-immune hydrops can have genetic causes also and can have infectious etiology also. So, here we cannot just say that it could be just because of infection. So, a total holistic approach needs to be followed. Yes, a needle test is required and amniocentesis. And here, in amniocentesis, along with torch PCR, we also need to send for microarray as well as for whole exome sequencing to rule out the genetic causes, which could also lead to non-immune hydrops.
So Neha, I also thought that testing the fetus was important to do with the microarray, whole exome and a torch PCR. But in the meantime, we also got a avidity test done along with the toxo. And here the IgG, IgM were both high and the avidity was low. So even at 28, 29 weeks, this is helping me to say that yes, there is a toxo infection. So don't you think we could do both of them and see?
Ma'am, we can, but the thing is this, that the reports come in a little bit of time. And at 28 weeks, I would like to have an answers as early as possible. And so I would like to do amniocentesis. And with this kind of presentation, we know that the if it is due to an infection, our PCR will come out to be positive. So we need a confirmatory answer for anything to be counseled to the patient or for management purposes. So rather than doing this test, I would directly proceed it for amniocentesis.
So both are right. So here I was little more suspicious it is toxoplasmosis, and so an amniocentesis was done for her. So tell me also, when do you do an amniocentesis? How much time from the time of the infection that you do this? Yeah.
So amniocentesis, when we are suspecting a fetal infection, and once we have confirmed that it is a maternal primary infection, then it usually takes 6 to 8 weeks for any kind of infection to pass on from the placenta to the fetus. So minimum period after the confirmation of maternal primary infection should be 6 to 8 weeks. And second thing is that I would always like to time this period as near as around 20 weeks, because at that point of time the fetal urination is also completely established, and we will reduce our false negatives because of low levels of virus in the amniotic fluid. So fetal urination usually gets established after 18 to 20 weeks. So timing at that point of time would be more beneficial.
Here she already has got a lot of markers for infection. So do you do an amnio and will you start her on treatment, or you would give her an option of termination by medical board?
I would give her an option for termination the medical board, because all the signs that has been seen, they are really in the severe category, and we do anticipate that the baby will have a severe neurodevelopmental delay, as well as there's also plus heart failure, because there's also hydrops and all. So option of termination will also be given to this patient, so that she can apply to the board, because it's at 28 weeks, so we need board approval. And in the meantime, till we are getting board approval, we can start her on treatment, but I think the course would be to apply to the board.
So if there is no amniocentesis is negative, spiramycin is better or pyrimethamine sulfadoxine?
If amniocentesis is negative.
Pyramycin.
Pyramycin.
Yes. So if if we don't see any kind of signs on the ultrasound and our amniocentesis says no, PCR is negative, Then spiramycin is a better choice. Then spiramycin can be used to prevent vertical transmission.
Yes, but here because they are markers, then it is better to start on
Yes.
sulfide.
Go for the triple
So
drug.
we were almost sure that the amniotic fluid will come positive, and we will also counseled her on medical board, and we started her on pyrimethamine sulfadoxine, waiting for the amnio report because we were almost sure there is an infection. And in the meantime, we also got a medical board termination allowed, and we this is how the baby was hydropic and the placenta was thick, and the amnio did not show any infection on the torch PCR report. So is it possible that there was an infection but not picked up on the amnio?
Yes, it is possible.
Yeah. And Neha also has told that, unless the infection has occurred and it's 6 to 8 weeks later that the amnio has been done, we might be missing it. So it might have been too early. That could also have been one of the reasons for that.
Or the virus might have come down because we had started her on treatment,
Maybe,
and that
this
is
can-
why it might have. So it is not always that you will be able to pick this up. So we just wanted answers, and so we repeated the torch avidity again and again. It was low avidity. So it was a toxo infection but not picked up on an amniocentesis. So our learning from here is presence of these markers on ultrasound will give us clue to evaluate the serology. Even late in gestation also, it's better that we do an amniocentesis to understand the cytology. And if there is an infection, pyrimethamine sulfadoxine, and if there is no infection but the mother has infection, then we would continue on spiramycin for these patients. Yeah, so with that background, let's go on to our next case. And for this, Dr. Sandhya, our obstetrician, and Dr. Sangeeta as a maternal fetal medicine. We know CMV is a very common, causes a lot of hearing and vision problems. So how does the risk of vertical transmission happen in CMV? Dr. Sandhya, you can take this first. Is it different from toxoplasmosis?
No. Sandhya ma'am not joined yet, ma'am.
Okay, then maybe Dr. Sangeeta, you can take it from here.
So the risk of transmission to the fetus is increases as the pregnancy advances. So in the first trimester, it is around 30 to 40%. However, in the third trimester, it is around 70 to 80% risk of transmission to the fetus. But the fetal or the neonatal infection will be higher if the fetus is affected in the first trimester. If the fetus acquires infection in the first trimester, and also it is more severe if the fetus acquires the infection in the first trimester.
And do we want to know whether it is primary or reinfection of CMV?
Yes, it is, because if it is a primary infection, then there is a higher chance of fetal affection. In this reactivation, the risk of fetal infection is very, very less.
So
So
there
yes,
is
it is
more with the
important.
primary infection. So if you have an IgM positive with low avidity, it is primary infection, the risk is high. But if IgM is positive with high avidity, it is an old infection and a reinfection, and the risk is going to be less. So here we have, I think Dr. Sangeeta, you only can take it. This is a endocrinologist herself, IVF pregnancy, 40-year-old, severe FGR with ventriculomegaly at 29 weeks of gestation. The neurosonogram looks okay except the ventriculomegaly. So are you suspecting infection or are you suspecting anything else? The uterines are normal, the ductus is normal, umbilicals are high.
Okay. So yes, definitely I will suspect the infection because it is associated, ventriculomegaly associated with FGR. So definitely I'll think about infection.
So now at 29 weeks with an almost high to absent flow in the umbilical artery, I went back to look at her earlier scans, and at 18 weeks also there was a discrepancy of 3 weeks, and there was ventriculomegaly then also. The CMV was as usual IgG positive, IgM negative. At this moment, is there a role of avidity?
Yes, definitely there's a role of avidity because if the avidity is less, then definitely we can say that it may be because of CMV infection.
But the avidity was high. So an amniocentesis was done. And here, yes, the PCR came positive for CMV infection. So is there a treatment available? Should we have started it whenever that first time somebody picked up an ventriculomegaly with FGR?
Yes, there is the treatment can be given. Gencyclovir and valacyclovir can be given if the fetal infection is confirmed. But without confirming, without turning the PCR positive for CMV, just empirically giving the treatment is not, I think, acceptable.
No, amniotic fluid positive for CMV.
No, now it is positive because beforehand, there was FGR with ventriculomegaly.
Should have done an amnio then itself.
So at that time, amniocentesis could have been done and then the treatment could have been started. So that would have definitely reduced the intensity of fetal infection.
So she reached absent diastolic flow and reversal of flow also. But she was a doctor. She understood that the morbidity is high, but she wanted the best because she was 40 years IVF conception. So maybe Dr. Elizabeth, you can take it. Will you allow her for normal delivery, allow the baby to die, or will you tell her ki we will do a cesarean section? She's 31 weeks, 600 grams.
With this setup, we have to give her a non-directive counseling regarding the prognosis. So with that prognosis, if she's if she wants a cesarean, you can take her up for that. But ideally, there is no direct indication to go for a cesarean because of a CMV infection.
Yeah, but now that she has reached reversal of flow, the doctors is also showing reversal. Dr. Sangeeta, she says, I want to save this baby. I understand everything. I am ready.
So then definitely we can go ahead with the cesarean because ultimately it's the patient's wish, which we have to honor.
So yes, it
because
was very difficult. Yeah, I'm finishing this last case.
Yeah, otherwise also there is end diastolic flow. She is not going to survive baby inside. So it's better to bring her out by Caesar.
So yes, 650 grams, very difficult decision, but the parents wanted to save this child, a CMV infected child, but cesarean was done and in the NICU, a reservoir was put in, then a ventricular peritoneal shunt was put in, a laser was done for retinopathy. She was in the NICU for 120 days, baby now 12 months, has got everything normal at the moment, and the patient calls me and tells me that things are normal. All CMV infection may not end up in a problem. So do I have 2-3 minutes or can I have to stop? So last one case, let us take it till Mona and Dr. Neha can take it. A non-immune hydrops at 19 weeks in an O blood group, O positive blood group. And the etiology is MCA is very high. We are thinking of what? Which infection?
Because if it is non-immune hydrops, because blood group is positive, then it's non-immune hydrops. We can think of infection. Parvovirus is one of the parvovirus, cytomegalovirus can cause this, and then we have to test for parvovirus in mother.
So mother was tested, found to have parvovirus infection. Is there any treatment available?
Yeah, we have to then look for the fetal anemia by doing MCA PSV. And if it is more than 1.5 mom, then we have to do intrauterine transfusion.
So this is all self-limiting. Only
Yes.
that time you have to tide over and give her transfusion. So any special precautions to be taken in parvovirus infection for transfusion?
It should not be, we should not over transfuse because there can be myocardial dysfunction. So it should
Yes.
be a bit slow than going fast.
Correct, yes. Because there is myocardial dysfunction, transfusing very fast and overloading may also cause a problem. But this is the only infection which has a significant treatment which is available. And if there is hydrops and we prove that it is parvovirus, then transfusion is going to help us. So I think we will stop here. Madam, do we still have time, or can I stop
No,
here?
ma'am, we have overshot the time, ma'am.
So I think
We
we
have overshot.
If it is a last case, Varnakar.
Last
If
question.
it is
Yes.
last case, then you say that it is gynae patient. So just
last
a
case.
clear message.
So Dr. Sandhya is not there. Sangeeta madam can take this. I have a primary gravida MD medicine. She has a student herself, has got a rash. How do I investigate for rubella for her?
So we need to check if she has been vaccinated with the rubella vaccine. If not, then definitely we should go ahead and do IgGM and IgG testing for her to see if there is rubella infection, because rubella infection, if encountered in the first trimester of pregnancy, has a very high chances of fetal affection and infection.
So here she had an IgM equivocal and IgG negative, and she was not vaccinated. So this is the only indication for termination in this patient because it was the first trimester. Last of all, Dr. Elizabeth, severe FGR, and there was echogenic bowel and a cleft lip. Do you think only FGRs we should investigate for infections? Dr. Elizabeth.
Yes, ma'am.
FGR alone, and there is some echogenic bowel that I am seeing.
Yes.
Dopplers were normal, and the torch is showing everything positive, and all IgMs are negative, all IgGs are positive, and avidity is high for everything.
No, we need to look into the other causes and rule out the other causes also, especially the chromosomal part has to also to be looked into, and the other reasons for the same before we can give them a diagnosis. For early onset FGR, it's a must that we need to rule out chromosomal abnormalities too.
Sometimes we think FGR is related to infection, but we don't have answers, and we just think, let us just go on how it is. And we thought the same way, that we continued, monitored, and took her till 37 weeks and delivered this baby of FGR. And see, there was a cataract in the eye, there was sensory neural deafness, this was a congenital rubella syndrome. So even this was a very old case when MTP was not allowed, so we did not do amniocentesis. So the answer is that amniocentesis, even late in gestation, should be done so that you don't have a morbid child like this born in this world. So yes, early FGR, think of torch infection. Rubella has got a very high problems and no treatment available. First trimester rubella has got major problems. And by the time ultrasound markers present, the insult must have occurred and the serology may come out as normal. Avidity may help, but not in the late trimester. And amniocentesis should be done even in late gestation. So I thank you, madam, for such an interesting panel, and all the panelists were so prompt, and thank you for calling me here, Dr. Sadhna, madam. Thank you.
What I wanted to give a message is that for every conceptual counseling, we should test for her rubella serology, so that if she is negative, then we should give her vaccination before she conceives, so that we can prevent the rubella in pregnancy.
Yes, ma'am.
Great panel, madam. So may I request the experts, Dr. Geeta Kolar and Dr. Anita Kolf, to give their comments.
Thank you. Thank you, Vandana, for those very nice cases where the challenges, dilemmas, and the decision making was properly presented, of course, with the panelists contributing. My only question in the first case was there was low PAPI. Was the uterine artery Doppler done? Was the placenta sent for histopathology? Because I know it's a panel on infections, but I did not have that information on that patient. And of course, APLA was done and subsequently pregnancy was managed. So at 15 weeks, sudden IUFT.
Can I just interrupt? Can I just interrupt? I think we can talk, but we can ask the backend team to share the link. Okay?
Yes, ma'am. Yes, ma'am.
So that because people are waiting almost 423 still, we can continue discussion, but share the link. Yeah. Very nice panel, Dr. Vandana, and all the panelists.
Yes,
so
madam.
that was my add
This
on
is
that.
a patient who's come to us after pregnancy, the next pregnancy. All that had happened somewhere else.
I'm just trying to put those action points. Because second trimester, then this another case you had, second trimester echogenic bowel ventriculomegaly, high avidity.
Posters will have to mute then everyone because then
Link has been posted in the chat box,
I
ma'am.
think the
It has
discussion
been.
is very important, Shashi. Anita and Geeta are wonderful. So it's
Okay.
good and people can do it. So it
Yes,
is among us
so
also.
we
So
had
Anita,
the
please,
doctor,
we really
young
need your.
doctor say she would do amnio, she would do whole exam and CMA. Where you rightly said that you should first look at the IgG, IgM, and that specific PCR you could do. If that is negative, go. Because she said at this point, torch is not needed. I would directly go for that. Probably we old timers don't agree. We go stepwise. We would first do the torch, see which organism is showing high IgG, high IgM levels, and then go. Right? And again, there, placenta for HP and autopsy for the baby. We should be able to complete the diagnosis when there's an infection. And because you said you did not have toxo, whether the placenta would have shed some light on infection there. It does add important information. So could we have done on the second case also where you had that baby where there was a strong suspicion of toxo, but your PCR was negative?
So placenta was sent for histopathology and it just showed a lot of edema and gliomas, but not infection. The placenta was also sent for again for a PCR testing, which again came as negative.
Came negative, yes. See, these are the dilemmas which were very, very nicely presented.
And the exome showed cardiomyopathy.
Yeah, but that was of
Variant of
uncertain
significance.
Yeah, I saw that. So
But
yes,
one thing, Anita, very nice input. What we in day-to-day say when the baby is not fine, and it is something very emotionally taxing to invite for tests and tests, and many people, I think it will be sharing. Many people will be sharing that they don't agree to it. So just a comment from Geeta, Anita, Vandana that what to do because they are emotionally exhausted. Yes.
So thank you, Dr. Sadhna and ICOG team. Manna, really interesting cases. I just wanted to make 2 points. I think I'm being a little controversial. I do believe that we should we should screen in the first trimester. I mean, rubella is mandatory, but now since CMV infection has got a treatment, I honestly believe that we should screen for CMV because we can do something about it. The other thing that I also believe is that a lot of obstetricians have this doubt that if IgM is positive, it means that there is fetal infection, and that is incorrect. I've come across cases where just on a IgM being positive, pregnancies have been terminated. What is important is the seroconversion, that a negative infection becomes positive. It is not IgM, it's IgG. So I think Vandana sort of illustrated that and when in doubt, do a amnio. The only caveat is that you need to have 6 weeks after you think that the woman has been infected and by the time you test. So definitely you cannot do an amnio before 19 weeks, generally speaking. But if you do an amnio, PCR is positive, please treat. There's treatment for CMV, there's treatment for toxo, there isn't treatment for rubella, but we can do a lot, and really, it's not the way it used to be. A lot has changed. Definitely.
Anita, what
I mean, for that
about
last case which
CMV?
had CMV, I would have started her on valcyclovir, and I wouldn't have even considered termination. I think your baby will do okay, Vanna, because that 40-year-old with a IVF pregnancy on treatment, there's even if the baby has sensory neural loss, it's treatable.
Yes.
So
Madam, we've started doing CMV screening for all in our government sector, and we are doing a study on that because treatment is now available and the guidelines have come up that you can treat antenatal CMV infection. So what you brought about is correct completely, that CMV should be evaluated in our basic protocol, but it's still not come in our guidelines still. We should start doing it.
ICOG can write new guidelines.
Thank you. Geeta,
So
Dr.
thank you
Geeta
so
Kolar.
much, Dr. San.
Thank you. It was great, Anita, to see. Dr. Geeta Kolar. Yes.
Yeah. Thank you. No other comments. We really enjoyed the entire session today. Thank you, Dr. Sadhna, and your team. Thank you. I don't have anything more to add.
Thank you. Thank you all.
Thank you, madam, for getting us all together on this.
I know. I mean, it was very, very nice cases, complex cases, I can say, where we really get a town and experts were there and totally covering fetal infections today. Step by step, I think 3 days we have almost covered, and really the program has been liked, and we have to see how we reach more and more people, Dr. Sadhna. Yeah.
It was wonderful, ma'am. Wonderful. And thanks for giving me the opportunity to
At least you
host.
have, because of that, you are sitting here
Always.
and listening. If you are not involved, you may try to go here and there.
The icing on the cake was this expert comments. They really
I think everything
discussed the
covered in
cases.
totality.
Yes.
So thank you very
My
much,
very
Dr. Sadhna ma'am, and the entire team. Fabulous 3-day certificate course. And I think everybody is waiting to know the answer. We still have about 7 minutes left.
I think we have 3 or 4 minutes. I've been like already there has been. Nilima, कितना time है अभी? MCQ में?
7 minutes, ma'am.
7 minutes more. Okay, fine. Today I was a little bit in and out, but listening to most of the things, and it's really wonderful.
And I'm unmute.
430 people have come at the end for the test.
Wow. Wait a number.
Mm.
Madam, when will be the next certificate course?
Next, we are doing after the managing committee meeting, because
Okay.
the office team will be busy, making presentations and preparation. So we are keeping it after the managing committee meeting. But on
28,
7th, we
29,
have
30 April.
7th, we have a master class. 9th, we have Guru Mantra. Okay. And then PG class will be on as usual on second Sunday. 22nd, we will have Gurukul. And the certificate course will be at
Afterwards.
the end. Yeah.
A lot of food for thought you have given us to study.
We have already
It will
fixed
last
the
till I-
topics. Everything is done and
Yes.
almost ready for May also. Now. Shashibala, I think I
Yes.
wanted that 7H CMEs we want to start. So,
Yes.
how many societies are there in Madhya Pradesh?
Madhya Pradesh, almost 40. I'll just give you the exact number. Big
So
ones
that
and
many
small
will be,
ones.
Pratik, that many will be more. If we can divide
10
it.
minimum we can take, because some societies like Singrauli and all, they hardly join, madam.
Okay, so can we take 10? You just see. Now, I mean, I want particularly the smaller societies, because
Then
We
Sagar
can take 2
Ratlam.
groups of 10 each, and therefore we'll have total 20 societies, the largest one addressed.
yes, they have 40 societies.
So
Yeah,
14.
so we can take 20 of the biggest and divide them into 2 groups of 10 each.
Yeah, we will do that, but we have to see that the message goes to all the societies so that they attend. Or you can involve one person from smaller societies also. Okay.
Yes. President.
Sadhna Gupta will have to see for UP. Anyway, we can tell our other Saroj Singh or other people from UP. I can tell them.
I'll coordinate with Shashibala, madam.
Shashibala, you coordinate. And later I have shared with you. Can you just frame it so that will become common for everybody?
Yes,
Okay, ma'am. I'll work
For
on it.
Sneha Buyar, which I have sent you, Pratik.
Yeah, I'll work on it.
So you work on that because Sneha wants to start working on that.
Yes.
Somebody is asking how to get certificate. You will get it after 1 week once you have passed.
The
and got
certificate comes to
50%.
you. You do not have to chase the certificate.
It's on the mail.
We are going to miss you tomorrow, Pratik.
I'm only a phone call away. One phone call, one message. मैं हाजिर हो जाऊंगा.
गोवा में कहाँ से आओगे?
No, Goa, I'm not there, unfortunately.
That's what I'm saying.
No, I was already booked by Dr. Rajatre 6 months ago, so I couldn't turn him down.
The demand for critical care.
Critical care is a good subject, but unless there is hands-on, certain concepts cannot be conveyed now.
Dr. Tarini Taneja wants to coordinate for UP societies. Every time she is muted.
Tarini and Dr. Kanchan can do the honors for North.
For North, we will ask them to do.
Yeah. I think Dr. Tarini logs in as a delegate, and usually delegates are muted by default. It's nothing personal, Dr. Tarini.
You ask us so that we can tell them to make you a co-host, Dr. Tarini.
Yes. Except for the co-host, they mute all others. That's why I got muted twice. Unless
Even
you
I
are a
changed.
co-host.
I came from hospital, now home. So I was muted again. Then again I requested.
Yes, ma'am.
Thank you, Anita, for joining.
Good night, everyone. I'll leave you to the quiz.
Yeah. Good night. Oh, so much. 10 minutes is so long, no? 1 minute.
So there are comment how we will get certificate. Whosoever will have more than 50% marks for all the three days MCQ, they will get certificate. There is one request to involve Rajasthan. So for sure, we will be very happy to involve Rajasthan. And still yesterday there was, I think 2 or 3 people in the 3 courts from Rajasthan as well.
Dr. Anju Soni was there, I think, couple of days before seeing her.
We will tell people from Kota, we can take Monica was there. Then we can take Dr. Taruchaya.
She's not President OB-GYN. Just be sent.
Whoever is interested, just send us your name. You have my number, it's listed on the website, or you can approach Dr. Sheila Mane ma'am and we'll do the niche course.
And Rajasthan people, please pick up the phone. This is very important. So picking up phone is very, very important to all who wish to participate.
Most people are
Shashi,
done, and I think there are just 10 seconds left.
Yes.
Yes.
Dr. Shashibala, you can go ahead and address the answers.
Okay. Yes, please share. I'll just. Yeah, shall I start?
Yeah, yeah.
Please
Yeah,
go
I'm
ahead. We're all waiting for you.
Yeah. First question, pregnant woman at 22 weeks shows fetal ventriculomegaly and intracranial calcification on ultrasound. Which infection should most strongly be suspected? The answer is B, cytomegalovirus. MCQ 2, which of the following is the gold standard test to diagnose fetal infection in suspected congenital CMV? Answer is amniotic fluid PCR for cytomegalovirus. MCQ 3, which of the following infections is most commonly associated with fetal hydrops due to severe fetal anemia? The answer is B, parvovirus B19. MCQ 4, hydrops is seen in all of the following fetal infections except answer is D, Zika virus. MCQ 5, intrauterine transfusion in parvovirus is done when MCA PCV is A, more than 1.5 mol. MCQ 6, best time to do MRI in fetal infections with cranial pathology is, answer is D, more than 32 weeks. Now MCQ 7, a pregnant woman of 10 weeks gestation is found to have Toxoplasma IgM positive and IgG positive on routine screening. What is the next best test to determine the timing of infection? The test is, answer is B, Toxoplasma IgG avidity testing. Now MCQ 8, a pregnant woman at 14 weeks gestation is diagnosed with recent Toxoplasma infection, but fetal infection has not yet been confirmed. What is the recommended treatment? Answer is B, spiramycin. MCQ 9, which of the following classical triad is seen in congenital rubella syndrome, CRS? Answer is A, cataract, sensory neuronal deafness, and congenital heart disease. MCQ 10, a woman 8 weeks gestation develops rubella infection confirmed by serology. What is the risk of fetal infection and congenital anomalies? Answer is D, more than 80%. MCQ 11, which of the following situation carries the highest risk of neonatal herpes transmission? And the answer is B, primary maternal genital herpes infection near delivery. Now, MCQ 12, a pregnant woman at 39 weeks gestation presents with active genital herpes lesions. What is the recommended management? Answer is C, elective cesarean section. MCQ 13, the following statements are correct regarding varicella zoster during pregnancy except varicella zoster immune globulin should not be administered to the mother and the neonate. Identify the false statement regarding Zika virus effects on pregnancy. Answer is C, microcephaly, intracranial calcifications, brain atrophy, ventriculomegaly, cerebellar hypoplasia on prenatal USG are not unique for congenital Zika virus syndrome. MCQ 15, which of the following is not routinely recommended to prevent early onset infection in neonates in the Indian setting? Universal, answer is B, universal rectovaginal culture screening at 35 to 37 weeks. And MCQ 16, all other indications for the TORCH screening during pregnancy except, answer is C, fever during first trimester.
I think here
17,
we want 1 minute.
Yes.
We needed to be more specific because
Yes.
fever with rash, you will have to. In
Yes.
fact, first trimester rubella is bad. So this
Your
question, I think we will make it null and void, Dr. Sadhana.
Yes, we can.
Because if it is with rash, no.
No, but there is no other.
We'll
No
any
other
answers.
thing. I think it is okay. It is okay because we want to say the message
Yes.
that fetal hydrops. These three is caused by the this thing, a fetal infection, but only fever does not. Because when it is no screening positive,
Only
then
fever does
ultrasound.
not.
Yes.
not
Yes.
only fever,
Except.
but we have not specified. So just see.
But the option is fever, only one
Except.
option of fever is there.
It is
That's
not
what-
fever. Huh?
That is where we can take it. Now, MCQ 17, in the Indian setting, the most common organisms causing early onset of neonatal sepsis are B. Klebsiella pneumoniae and E. coli. 18. Which of the following vaccines is safe to give during pregnancy? The answer is B. Seasonal influenza vaccine. And MCQ 19. Which of the following vaccination is contraindicated in pregnancy? Answer is D. Varicella. And what is the time to give Tdap vaccine in pregnancy? The answer is D. 27 to 36 weeks. That's all. So
congratulations. I think most of you have passed and you have declared your results also. So very nice.
I think I have
Intense
passed
study.
on all 3 days, so I should get a certificate as well.
Okay.
Intense study going on, madam. Thank you. Thank you so much.
Okay. Thank you.
It is
So all,
Goodbye, everybody.
So
Take care. God bless.
I will be giving formal vote of thanks. Formal. I want to give formal vote of thanks. It is 3 days, and our all coordinators and conveners are doing such a great work. So thank you very much for joining in big number. First of all, thank February, but because February was endometriosis awareness month, so it was scheduled for March. And Pratik, you are always a very, very big support as a secretary ICOG. My gratitude to my all 3 days co-convener, Dr. Pratibha Singh, Dr. Achla Batra, Dr. Shashi Bala Bhosle, who have put as a coordinator as well as a faculty, gave a very, very nice input and very hard work. Being a coordinator is a very, very like a ground root work, and Dr. Moshmi, Dr. Kanchan Prasad, and Amrita, they have done wonderful work, and they are all calling and confirming. And Pratik, I think Sheila, you will appreciate that we didn't have any absent faculty. Every faculty, every chair, every panel was there, and that is because of the very hard work of our all co-convener and the coordinator. So we extend a warm thanks to all faculties. They are very expert, experienced in their respective field, and the sharing of knowledge to our all members is something which we look forward. Thank you very much for your precious time, and thank you very much to all participants, like in all
Your
the
voice
numbers,
is
good
breaking.
number of registration and to make a new program a little bit. Okay, my voice is breaking. So thank you very much. I think
IT.
it's okay. So
IT
final
team,
comment from Pratik.
IT team.
Madam, record
IT
is
हमारी ICOG के अच्छा, they are part of memory. So my voice is breaking.
You are breaking records.
It's okay. I think thanks to Nilima, the backend team, the IT team, and everybody. And thank you all for being there for 3 days.
Thank you.
Thank you is an understatement.
Thank you,
have
Sheila Mane, madam,
disseminated
for your guidance.
so much of knowledge you have given us, madam. Thank you so much. It's an understatement. Thank you is
My request is that I want to see it reaches more and more people, because
yes.
some are now you can see the request today that how do we know what next month, So we
Yes.
have to really work for that, Pratik, to see that
Yes,
how we see to it that the message is sent to president and secretary, but I'm not sure that it gets. I just want to know who is the president of Gorakhpur.
Dr. Deepthi Chaturvedi is the president.
Yes.
Does she get a mail or a? Does she get a mail or a flyer from
Yes,
FOGSI?
yes, she was there, madam, on the first day.
No,
Dipti was
not
there.
like that. Does she get it as a president or official mail so
Yes,
that
ma'am.
she can share it in her society group? Means I am just trying to find out the ways to reach to everybody. So
We
Amrita
now
is
have the
helping out.
ICOG mobile phone, madam, which has just started functioning. So we'll create those groups and we'll broadcast to all the presidents and
I think,
secretaries
yeah,
as
we
well,
have to
which will
do
make it
something.
easier to Chair.
We got a phone now, so we will have a broadcast group. Okay, Pratik? I
Yes,
think
ma'am. It's already
that
in process. I've already spoken to Nilima today about it.
today you were in the office. No, we got the phone.
Yeah, I spoke to her. Yes,
So
yes.
I'm so happy. You know, I told Dr. Suvarna that ICOG also needs a phone. Okay. And Pratik, we should also have the broadcast of all the FICOG members.
Yeah, we are gradually going to start implementing that.
Yeah.
I've spoken to Nilima today.
First,
will
we will
gradually
have president, one group, secretary, one
Exactly.
group. President
Correct.
and secretary, because we can reach them early.
And all the office bearers.
And all the office bearers.
Yeah,
Okay.
that's the first step. The next step is gradually make groups of all the fellows as well.
All the fellows, yeah, fine. That and then the medical colleges later on.
Yes.
Yeah, we'll
HODs.
hopefully do that after the managing
Rishibala,
committee.
I give you that responsibility. MP का पूरा every medical college HOD.
Yes,
Okay,
ma'am.
साधना जी, अगर आप and मैं सब सरोज और सबको बता के.
I'll do it.
UP के we'll see. Kanchan, I had given the responsibility. So trying to see that we
Yes,
reach
madam.
more
I
and
share
more.
in that MPOX group also. All that group also. That we all have.